YouTube. I believe Senator Hicks is also present. His microphone and video are just off.
There, okay.
Here you go. No, ma'am. Here. And Malou.
Stefan.
Our director.
Director, welcome. So we're beginning the Department of Health on our second Monday of the JAC supplemental budgets, and Director Caballos, welcome, and please move forward with your budget. Good to see you. Hi, Stephen.
Sir, you're muted.
Director Ceballos, I believe you are muted at the bottom left of your screen. You can turn that. Thank you.
Thanks. Mr. Chairman, members of the committee, I'm Mike Ceballos, Director of Wyoming Department of Health. I'm going to be joined today by our Deputy Director, Stefan Johansson, and our Chief Financial Officer, Eric McVicker. I'll also have our 4 division senior administrators on answer for questions that you may have throughout this presentation. Stephanie Pyle is our public health, leads our public health division. Terry Green, our healthcare financing. Lisa Oswald, our aging, and Matt Perry, our behavioral health. For today's presentation, the department will be focusing on Step 2 and Step 3 budget reduction plans. In addition, we plan to discuss and we're prepared the exception request listed in the supplemental budget. And after our overview, we're more than happy to go through each page of the department's budget. So starting with the budget reductions, Step 2, and this will again be on the document that you referred to right before you left for lunch. The Step 2 reductions total approximately 89 million in state general funds, with an accompanying 48.9 million in loss of federal funds, or a total of 138 million. However, in Step 2, we were able to leverage some one-time savings and other revenues of approximately 21.5 million, which made the realized total cut approximately 116.5 million. You will also notice in Step 2 that we made reductions across several categories. We've tried to categorize these cuts in 4 areas, and it'll just make it easier to identify the type of cut that was implemented across each division. For example, in Step 2, we made over 6.5 million cuts to administrative costs and contracted services, 5.5 million in full program eliminations, and over 53 million in program reduction. So you can see this on page 2 of the summary document. For our Step 3 reductions, totaling approximately 47 million in state general funds, we also had an accompanied loss of about 18 million in federal and other funds. So the total cost of the cuts there was approximately $64.4 million. Just generally to outline the principles and how we went through this, the Step 2 reductions are in process, and the Step 3 reductions are currently proposed for your consideration. Across all funding sources, the overall budget impact of Step 2 and Step 3 include over 200 million in reductions and one-time savings, which is approximately 13.7% of the department's total budget. These cuts were painful, and they'll have a material impact on our residents and providers in our communities. In Medicaid, we've had to reduce provider reimbursement rates to most types, including hospitals, clinics, behavioral health providers, etc. And we have limited some service areas and eliminated some programs altogether. In behavioral health, we've tried to make cuts to our developmental preschool program and also the community mental health and substance abuse contracts. In aging, we've had to eliminate a state general fund only program for in-home services. And in public health, we've had to reduce funding for vaccination supplies to providers across the state. But these are all just examples, and we'll get into the details on these reductions shortly. It's worth mentioning that in closing, the principles that the department has used to structure these particular cuts. As we have told this in other communities many times before, the department's budget has some peculiarities. 90% of our budget dollars, as we've shared before, goes out the door in the form of payments and contracts to providers, small businesses, and local communities. Of the remaining 10% that's used for staffing and administration, most of that is for our facilities and field offices in your communities. 91% of our general fund budget is located in 5 program areas. So as you know, when our department has to cut, these cuts are felt hard by residents of the state. And there are very few ways to make budget reductions at this scale without reducing services and programs. We wish there wasn't the need to have to do that, but there just isn't any other way to get there. Because of this budget structure, I directed our staff to prepare our cuts with the following principles in mind. First of all, we did avoid just blind across the board reductions. We also looked to minimize the impacts on our most vulnerable populations. We minimized impacts on behavioral health continuum and our safety net facilities. And we are exploring and explored options for one-time saving revenues that revenue increases for the 21-22 biennium. Generally, I also was just mindful as I looked at this, the impact that our budget does have on the health community, the healthcare population out there. And so really was careful in looking at all that we did, and also tried to find services where maybe there were multiple ways to provide those services, and then try to focus if there was a way to save and go back to just one outcome, then would look for that as well. So we're continuing to try to serve our priority populations as we've described them, and then work with a couple initiatives that have been ongoing with the legislature through interim committees this summer. But with that in mind, then Stefan and Eric can now provide further detail on the budget reduction plan and walk through the entire budget with the committee. So thank you, Mr. Chairman, and the committee for the opportunity to testify, and we'll dive right into the budget. So Stefan.
1 second.
Yes, sir.
Are there any questions for the director before Stefan takes over the helm?
Mr. Chairman.
Go ahead.
Thank you. Director Ceballos, when we read your guiding principles and we look at your reference, and you just said to minimize impact on the most vulnerable populations, we as legislature get a little cynical on the use of that term, because when we start cutting budgets, everybody's population is the most vulnerable on the face of the earth. And so help me understand, you told me that it's the most vulnerable populations. Name me what those populations are.
Well, in a couple of cases, Mr. Chairman, Representative Larson, one of them is exactly one that you've been looking at. It's our mental health population there. And even the work that you've been doing over the interim to look at what of those populations that we serve would we prioritize higher, and with reduced budgets, then how would we walk that down? So that is
Director Ceballos, and I'm not questioning what or how you've done it. I appreciate that. It's just that we get confused because everybody has a most vulnerable population. And so I'd just like you to name me who the most vulnerable populations are that you're addressing, and then we'll get to the details. But when we get to that population, I'd like to just know from your comments that that's what the population is. And so one of them is the mental health and substance abuse. What are the other most vulnerable ones that you directed your staff to minimize the impacts on?
Mr. Chairman, Representative Larson. Yes, and also that would include a care with the EIEP, with the early education population that we've been looking at. Certainly, there's aspects of our senior services that we've looked at particularly support our senior centers across the state. There's also much of the work with Medicaid. And as you look at those particular populations there, and particularly the importance of the dollars that are served within those, then it's been another specific set of programs we've looked. So specifically there, it's try to minimize the amount of the cut that we would be going out directly to providers. And then finally, with our public health, there's clearly been a lot of work this year on all that we've had to do with our public health nurses, with our women, infants, and children program that's been there. And then finally, I would say that the two specific places that I would also mention are the State Hospital and the Life Resource Center. Our commitment to this committee at the beginning of the year was to get those facilities fully staffed up, and again, to work down our wait list to 0 there and make sure that that's put in a position where we can implement it. So those would all be examples of where we've minimized or had a focus on minimizing cuts.
Okay, any further questions for Mike?
Mr. Chairman.
Okay, please.
Mr. Chairman, thank you, and Director Ceballos, thank you. You know, a question, and I've picked on all agencies, I guess, but the last one, because I think they probably did the best job I've seen so far of balancing cuts to what I would call agency cuts versus cuts to people. And I look at your budget, and I know it's crossed all dollars, but I look at your budget and your 100 series cut 0.5%, 200 series 3.4, 600 8.4, and 900 4.6. And so, you know, I guess as you guys move through this budget and talk about it, explain to me why you are prioritizing what looks to me like you're prioritizing your employees over people out in the country. And so that I want that addressed as you move along. And then another question I have, and it can be for Stefan or whoever later. I didn't count up how many vacancies you have, but I'm interested in what your total number of vacancies are currently. And then what percentage of those vacancies, more importantly, what percentage of those vacancies are going to staffing the Wyoming Life Resource Center and the state hospital to understand, you know, okay, what's kind of going on there? We give you this authority, this flex. You guys did a great job. But if I could understand a little bit more about what that looks like on your vacancy list when we still look at pages of vacancies when other agencies have stripped them out during the course of these cuts. So that's my questions for as you go along. Thank you.
Mr. Chairman and Representative Summers, one interesting facts coming into this job is the amount of direct care workers that we have here. And even if I don't count some of the folks in public health, if I just look at the people that are providing direct services to the public, more than 80% of our staff does that. And that is in those facilities, the hospital, the Life Resource Center, public health nurses, our public health lab. So again, we did not cut those services, and that was a decision that we've made. I think since the beginning of the year, and we asked this group to fund 49 positions at the state hospital, we took 20 out of our organization to allocate to the state hospital growth. And since then, we've reduced another 9 essentially in the budget cut, the phase 2 and phase 3. So we'll be around 30 cuts that are predominantly coming from what I would guess, and again, Representative Summers, listening into the past appropriations meetings, what you're looking at, those kind of administrative positions that where we would have some ability to do that. I think that Stefan and Eric can provide you the specifics on the number of open positions, but we've been managing that very tightly. But that's just a general broad perspective on what we'd share, and I'll certainly let Stefan and Eric give you the detail as you're going through each department and each page.
Thank you, Mr. Director.
Representative Steinmetz, or I'm sorry, Senator Steinmetz.
Thank you, Mr. Chairman. I was just, since you brought that up about the direct services director, could you please give us the cost of providing those direct services? Because that would give us an idea what we're paying to provide those services. Thank you, Mr. Chairman.
Chairman Nicholas, Representative Steinmetz. We'll go through all of those directly. I think, again, as we talked about, 90% of our $2 billion budget is going towards those types of services out there. And I think we can break that down. But even of that remaining amount, there are other services, again, like our women and children, women, infants and children's program, our public health nurses that are out there, and our public health lab will be additions to that amount. So I think we can work with you on giving you specifics for each one of those.
Further questions? If not, all right, please proceed. Stefan, you're up.
Thank you, Mr. Chairman and Mr. Co-Chairman, members of the committee. My name is Stefan Johansson. I'm the Deputy Director for the Wyoming Department of Health. Just to reiterate a few things, if you'll bear with me on the overview document that you have in front of you, some of the things that Director Ceballos mentioned, I'd like to just briefly elaborate before we jump into the budget book. On page 2 of that document, that summary document, what we've done before with this committee, and hopefully it's makes our testimony and our hearings a bit more efficient, is to just give these overviews to see in a bit more simplistic fashion in the budget book exactly what we've done. And typically in a hearing like this, we would be going over our exception requests or any changes to the budget. But obviously this year with our step 2 and step 3 reductions, it really is the elephant in the room. So looking at page 2 on that document, you can see 3 tables. One is our total step 2 reductions, which have been or are in the process of being implemented. Table 2 is our proposed step 3 reductions. And then table 3, if you were to take both step 2 and step 3 as all fully approved and implemented, that would show you the ultimate impact across our divisions of what percentage, as well as the raw dollars that we cut out of the general fund budget. And also, as Director Ceballos mentioned, we tried to collapse them into some more discernible categories. And obviously, we'll get into the weeds and get into the detail in each unit when we go into the budget book. But we wanted to give a little bit of a visual to the committee to show the dollars that we cut out of administrative or contracted services, full program eliminations, and then obviously what represents the lion's share of the department's cuts, just because of the way our budget is structured, is program or service or reimbursement rate reductions. So you can see those percentages broken out by those categories as well as by each division. And to Director Ceballos' point, again, we really tried to avoid blind across the board reductions. That was at the direction of our governor, as well as at the direction of Director Ceballos. So you can see really the inequity across our divisions, which looks unfortunate, but I think it's much more, again, a lot of these cuts were much more targeted in nature than telling each division and each unit that, here's your 9% cut, here's your 4.5% cut. Now prepare it across all of your different programs. You will see some inequity here, and we are, again, more than happy to go into the detail. If you'll turn, Mr. Chairman and committee, to page 3. I'm sorry, it looks like Senator Kinski has a question.
Go ahead, Senator Kinski.
Thank you, Mr. Chairman. on page 2 at the bottom right-hand corner, it says step 2 plus step 3, total 135. Right above that, it's one-time savings and revenue. And I think the revenue is CARES revenue. It's not ongoing revenue. It's just one-time revenue, if I recall. So is it fair to say if I subtract the 23 million one-time savings and revenue from the 135, I get 112 million that's ongoing. The others are just transitory. Do I have that right?
Mr. Chairman, Senator Kinski, you do. And if you'll flip to page 3, a nice segue into the next discussion point, that's where you'll see a breakout of the one-time savings and the other revenue increases that we were able to capture, especially in step 2. And to your point, Senator Kinski, it's a little bit of a mixed bag. So much of these were intended as one-time savings. So for example, you'll see a lot of, for lack of a better term, capturing a 6.2% federal match increase. And Senator Kinski, you're absolutely right. That is related to the CARES, to the coronavirus public health emergency that is still certainly with us. But in the last half or so of the 1920 biennium, that match increase went into effect from the feds. And it's really intended for during the public health emergency, if the economy were to decline and we see additional enrollment or expenditures in Medicaid, that's the reason for the 6.2% match increase. However, in the 1920 biennium, in those final months, we did not see that enrollment increase in Medicaid. So therefore, we were able to capture some general fund savings there by nature of having that increased match. So you'll see a couple of categories in that table, which is table 4 on page 3, that really relate to what you're talking about, Senator Kinski. But there's some other categories there of additional revenues, like increasing our fees for vital records materials, so birth certificates, death certificates. And I will just mention that in this budget book, each one of these one-time savings or alternative revenue sources, they have been biennialized into our standard budget. And that's something we intend to discuss with the committee as we go through this budget presentation. Since we know that the public health emergency will not last forever, we will have to have a discussion about additional funding going into the 23-24 biennium, or on the other hand, if this were only one time, then potential additional cuts for the 23-24 biennium if the revenue situation in the state did not improve over the next 18 months or so. Senator Kinski, that's a long-winded answer, but did I answer it somewhat?
No, thank you.
So, Mr. Chairman, I won't belabor the point on page 3 here too much longer, but did want to again highlight a few things in addition to that capture of federal match increase. You'll see the $5 additional surcharge on vital records. We are implementing that. We have to do that through emergency rules, so it takes a little bit of time, but we should be up and running with that here in the next couple of months. And we estimate again approximately $500,000 in additional revenue. You'll see in one of the rows down there a 10% reduction to our Title 25 per diem. This is related to clients who are civilly committed to the state hospital, but are awaiting admission because of our wait list at the state hospital. And those clients are often held in what we call designated hospitals that provide Title 25 services. That per diem has been $677 per day. We are cutting that by 10%. So effectively on January 1st of next year, that per diem will reduce to $610 per day. And finally, Mr. Chairman, you'll notice on the penultimate row here in table 4 that we did eliminate funding that was associated with Senate File 150. To remind some of the committee members, a couple of years ago, you all passed a bill that was related to innovation funding, essentially giving the department $1 million to accept applications for innovative programs related to long-term care costs and some other areas. We reluctantly removed the funding for this. We had not received any applications yet, but we did notify all of the entities that were potentially interested that this program was going to be put on hold. while we reviewed the budget situation and while the governor reviewed the revenue situation of the state. And ultimately, the decision was made to take that funding off of the table. So that was, again, located in the director's office. And that was one-time funding. Again, that has been biennialized in the budget. And so what you'll see, and our CFO can correct me if I'm wrong, what you'll see with that $1 million is we had to put it somewhere to cut for 23-24 because we just don't have it in the director's office. So that fell on the shoulders of the Division of Healthcare Financing, and we'll get into those details here shortly. And last, Mr. Chairman, we did reduce some contract expenditures at the Life Resource Center. Again, I think this could be safely biennialized. It's included here in our additional one-time savings or revenue just because of some of the uncertainty around the funding sources. Typically, the costs at the Life Resource Center are 70% federal, 30% general fund, but we don't know at this point by reducing those contracted services. There was some excess that we believed we had in meal preparation and some other areas. We don't know if we will ultimately lose that estimated $980,000 that you see in the federal fund column. So we included on this table as somewhat tentative. Moving on, Mr. Chairman, to page 4 of your summary document. Again, I will sound like a broken record with this committee. We've presented this visual to you a number of times, and to echo what Director Ceballos said, I think it's important before we dive into the budget to not only answer some of the good and fair questions like Representative Summers just brought up, but the department's budget structure is always just very peculiar in that so much of our general fund budget lives in just a handful of areas. And you can see on page 4 on table 5, that top row of about 5 program areas that really represents the lion's share of our budget. Going down below that, you can kind of see how that general fund cascades. And I wanted to point out, Mr. Chairman, that if you look at the general fund and federal fund columns, you can really see, how some of these program areas are weighted when it comes to their federal funds that are in them, and kind of start to understand, like we have all come to understand in this department, that there are general fund dollars available in some of these smaller programs, but often come at quite a large federal match or a federal grant, and it makes it very difficult if we were to eliminate, the bottom half of this table. We wouldn't really approach our cut target for this current biennium that we've been given. So again, Medicaid, which includes our waiver programs, our community mental health and substance abuse funding, developmental preschools, and our 2 behavioral health facilities, that's really, to put it bluntly, where all of the money is. So when you see our service reductions, reimbursement rate reductions, contract reductions, they're all reluctant decisions that we have to make, but at targets like this, the scale is such with our budget that we really have to target some of these areas. And I think it's fair to debate, where we did or did not, in your view or your perspective, do enough in certain areas, and we're more than happy to have that discussion. But at 13-14% general fund cut target, with over $1 billion, 1.4 billion sitting in our Medicaid and waiver programs, it's just difficult not to reduce services. And we think we struck the right balance with step 2 of being able to leverage savings, being able to leverage utilization reductions to minimize those impacts while still generating the savings. But in step 3, it will be a tougher discussion with some of the decisions that you'll see in the budget as we go through it. And finally, Mr. Chairman, to wrap up this document before we dive in, if you look at page 5, you'll see the exact same table, but just tweaked a little bit to only reflect the general fund budget of those program areas. And then you can see, kind of going across each column, what we did in step 2 in terms of reductions, what we did in step 3, and what we did combined. If you were to take step 3 all together, you can see the totals in the table there. I will mention that you'll see the note below. This does not include the one-time savings and additional revenue. We, for simplicity's sake, elected to keep that out because it was a bit peculiar in how we were able to leverage those savings. So, Mr. Chairman, I'll stop there on the overview before we dive right into your budget book. but certainly don't want to drone on and on if there are questions before we dive in.
Questions for Stefan before we proceed?
Mr. Chairman.
Mr. Chairman.
Senator Kinski.
Thank you. Stefan, I'll ask a question that's been asked. I've heard it several times by Chairman Bebout. On the mental health and substance abuse, the proportion of general fund to federal fund is 10-1. And some time ago, you'll recall, I sent you a chart that I'd looked up on the web, and we're not the highest percentage of general fund to federal fund, but we're up there. And there's some states that their federal funds far outweigh what they spend out of their general fund for mental health and substance abuse. Why is our percentage so high there? And give us some options as to policy choices that we might make if we want to reduce that general fund subsidy, that general fund spending on mental health and substance abuse.
Go ahead.
Chairman Nicholas and Senator Kinski, it's a good question. You're right that relatively speaking, in comparing our community mental health and substance abuse funding to other states, our proportion of state funds to federal funds is higher than some of our neighbors and some of the states across the country. The reasons for that, we could talk for hours about that. A lot of it is a factor of an artifact of history from how these programs in Wyoming were developed, really in the late 70s and early 80s as grant programs to ensure in a rural state, infrastructure for community mental health and substance abuse services, essentially places where people could go to get help. And then over the years, over the decades, really the landscape of coverage for mental health and substance abuse services has indeed changed. Private insurance covers more of the services. Medicaid has covered more of the services in the past. And with the Affordable Care Act, many states who did expand their adult coverage under Medicaid through the expansion programs have shifted a lot of reimbursement from what was state-funded community services to Medicaid-funded services. So quite a variety, Senator Kinski, of reasons why it looks like it's more heavily weighted on the general fund side, but you're right, it certainly is. In terms of options moving forward to change that or to leverage additional federal funding, the subcommittee that you and Representative Larson are chairing, I know a bill has passed out of the Joint Labor Health Committee that really looks to prioritize not only the folks that would be covered under this community program, but also the dollars there would be, in our view, a start to a discussion about what's the appropriate funding source and what's the appropriate legal mechanism for that type of coverage. So just kind of a few answers there, Senator Kinski, but you're absolutely right. You look at our table on page 4 and 5, and mental health and substance abuse is our second largest line item in the department. The options to change that with additional federal funds do involve statutory changes and really policy changes to the way that the state chooses to fund these services and the populations that it covers.
Follow up?
No.
All right, Mr. Vice Chair.
Yeah, thank you, Mr. Co-Chairman. Just a real quick question on the summary on table 5 of those 9 positions that you're looking at eliminating. Were all of those 100% generally funded positions in step 2, step 3?
Mr. Chairman and Vice Chairman Hicks, I'll have to defer to our CFO there. I know there were general funds, obviously, in every position. I'm not sure, I don't have it in front of me, the exact breakout, but I believe there were other funding sources in some of those. Eric, do you know that off the top of your head? And if not, Senator, we can certainly follow up.
I think Kevin just jumped on.
Mr. Chairman, when they go through their budget page by page, they will delineate those positions and the funding associated with it. But if Eric has an answer, good enough.
Mr. Chairman, Senator Hicks, yes, there was one position that I'm seeing as I go through here that had roughly $18,000 of federal funds. All the rest of them were 100% generally funded.
Okay, thank you.
Mr. Chairman, another question, and just looking at going through and running some numbers on the budget. So the question I have when we reduce the grants and aid payment by the 111 million, and I understand that's probably a combination of general fund and other funds. That's roughly about 6.8% reduction in the grants and aid program. So those are being distributed out through the Department of Health. But when I look at the reduction in your personnel, it's less than 0.5%. So my question is, if we're reducing our budget by 6.8% in grants and aids, isn't there a reduction in demand for staff to be able to accomplish a commensurate level of work? So the question is we significantly reduce the workload by distributing those grants and aids funds, but I don't see the commensurate level reduction in staffing.
Mr. Chairman and Vice Chairman Hicks, it's a good question. Not to belabor the point, but I will echo what Director Ceballos said, that the vast majority of our 100 series does exist out in our facilities and field offices, where we did minimize our reduction efforts. But when you see the 9 positions in the 100 series that was reduced basically in our administrative offices, you're right that we have made significant reductions in our Medicaid program as well as our contracts. I would just offer Senator Hicks that in terms of the scale, primarily with the Medicaid program, a $1.4 billion program, our administration in that area in terms of staffing is very light. In fact, with that insurance program at $1.4 billion, we operate at around a 2 or 3% administrative cost to do that program. So our staffing, I would argue respectfully that it is light, with the lion's share of the funding that does exist in Medicaid and the Division of Healthcare Financing. When you compare that to an insurance product in the private market, you see often administrative costs of 10, 15, even 20%. So that's one answer, Senator Hicks, of why you'll see a bit of an inequity in the reduction of 100 series and personnel. And the second thing I would offer, both to your question, sir, as well as Representative Summers, because it's fair. We do have a personnel here in Cheyenne distributed across our divisions administering programs. And when you look at the table in our budget summary on page 4 or 5, you will see, a lot of those programs below that top 91%. That the staffing that's supported there is often supported with general fund, but to manage, larger federal grants. And philosophically, we could go through, for example, the public health division and reduce a lot of personnel, reduce a lot of staff, but it would come at the expense of grants and services like public health nursing, WIC, some of the things that Director Ceballos mentioned. And we avoided that just because, the question is the juice worth the squeeze there, when maybe the staffing is supported by a general fund match or even fully supported by the general fund in some of those programs, but outweighed pretty heavily in the grant that is received from a federal or another source. Again, not trying to overly take a position here, but we could most certainly look, if directed, to reduce personnel, to have reduction in force, but you would see quite an inequity with the amount of federal funds that would be lost that do support efforts in the communities. And Director Ceballos, if you have anything to add, please do.
Okay. Please proceed.
Mr. Chairman.
Oh, I'm sorry. Go ahead.
No, that's fine. Mr. Chairman, I'm going to pile on a little bit. I know I've taken one stab at this, but Stefan, when I look at this and I look at your budget, 12% of your budget is in the 100 series, 12% versus a cut of 0.5%. And so we've already discussed that, and you've expressed that, but it's still a frustration for me. And then the question I asked before, and I'll re-ask it, or you can provide me later, but you've got all of these vacancies, and we've been very kind with these vacancies for a long time. And so what percentage of those are you using to do the reorganization that we were interested in seeing? And what percentage is just sitting there? I mean, 20 months, 24 months, you name it. And I mean, they're hard to fill positions. You're waiting for facilities to come up. I get it. But as a, just as a legislator looking at this, I have no idea how much is fluff and how much isn't. And so it's kind of for you to help guide me through that.
Mr. Chairman and Representative Summers, we're more than happy. We'll get right on that, preparing that breakdown for you. In terms of the figure you mentioned of around 11% of our budget being in the 100 series, I would just mention that I believe 72% of that 11% is staffing that's out at those facilities and field offices. So that those staff live outside of Cheyenne, are not program managers here, not administrative staff. They're basically doing direct care work out in the facilities or providing direct services through our field offices. So, but won't candy coat it. There's still certainly around 29 or so % of our 100 series is here in Cheyenne. But like I mentioned before, while that is a general fund percentage, we do have, a lot of these offices here in Cheyenne have a significant amount of federal funds that support those salaries as well. So Representative Summers, I hope I don't sound dodgy here. I really mean it sincerely that we can look across our enterprise for reduction in force and reduction in 100 series, but it does come at quite an expense with grants and with federal sources, and would still be very difficult, if not impossible, to go across the board and eliminate staff here in Cheyenne and still hit the cut targets that we're directed to implement.
Okay, please proceed.
Mr. Co-Chair.
Go ahead.
Yeah, just a follow-up on that, Stefan. Out of those 9 positions that were eliminated, were any of those RIFs, or are they just existing vacant positions that you've given up?
Mr. Chairman, Senator Hicks, none of those were reduction in force.
All right, thank you.
And Mr. Chairman, if I may, again, we'll prepare the breakdown per Representative Summers' question about how we're tracking with the facility staffing project that we worked with you all in the legislature to implement earlier this year. I will mention that some of the COVID-19 impacts have delayed, as was mentioned before, have delayed some of our recruiting efforts and obviously some of the projects at those facilities to come online when they were intended. But we're more than happy to prepare that information. We did repurpose, as Director Ceballos mentioned, 20 positions from the department earlier this year to be repurposed at those 2 facilities. And then with the remaining 29 positions that were new, we had for those a $17.2 million exception request in front of you all last year. By not only repurposing those 20 positions, but also internal department funding, we were able to reduce that $17.2 million exception request for staffing to $1.7 million. And we are on track to be able to continue to implement that and essentially fund those positions internally. So Representative Summers, to your question, a lot of those vacancies that are on the report, you'll see more often than not are located at our, outside of Cheyenne in our facilities. But with the vacancies that we repurposed, like I said, I believe 15 or so of those were from the central office here in Cheyenne. So those will show as vacant for a longer period of time. And then in a department like ours, both with direct care and with our administrative offices, we do see a fair amount of turnover and churn in those positions. So Eric and I will get together and prepare that information for you post haste.
Yeah, I would just comment, Stefan, that whatever we can get before Wednesday or Thursday at the latest. Otherwise, you might be coming back and asking for help.
Yes, sir, Mr. Chairman. We'll get right on it.
Mr. Vice Chair.
Yeah, Mr. Co-Chair, Stefan, when we go through the budget on these positions that you've eliminated in steps 2 and 3, when we get to those positions, I will ask you now, or whoever's going to present those sections, to characterize those positions, whether they're either service positions or administrative positions, and where they were located at.
Mr. Chairman, Senator Higgs, happy to give you that detail. For the most part, they were all administrative. There was some artifacts of previous, years and years and years ago where the administrative office here used a position that was originally dedicated to the facilities, but we're happy to walk through that. But all of the 9 positions that you see, I believe with maybe 1 or 2 exceptions, were all administrative in nature.
All right, thank you.
Okay.
Thank you, Mr. Chairman. If you will turn in your budget book now, we'll jump right in to page 53. And that seems like a deep place to jump to in the budget, but that really does skip over our, a little bit of the agency summary, agency overview, and the prioritization of our programs, which you all have seen before. And from the previous budget book, there really have not been many substantial changes to the priority listing. We're happy to answer questions about that, but for the sake of expediency, we thought it would be best to dive right into our exception requests, our step 2 and step 3 reductions, and then do a page turn with the units of the budget. Mr. Chairman, I'm happy to pause if there were questions about the first 50 or so pages of the budget, but otherwise we can jump right in.
Well, let's just jump in. We'll drag you back wherever we need to.
Thank you, Mr. Chairman. On page 53, the first table that you'll see is our exception requests for the supplemental budget. There's 4 exception requests this year, but I wanted to provide a little bit of detail as some of the situation with them has changed. The first 2 that you see as priority 1, this is for the reinstatement of some tobacco settlement funds that were removed during the previous session. I believe there was language in the previous budget bill where again, some of the tobacco funds were removed and replaced with general funds, but those general funds were cut in half to be revisited in the supplemental session. So I'll hand it over to Eric McVicker or Kevin Hibbert at the budget office to describe what's going on there. But essentially, this was a leftover from
Mr. Chairman.
Go ahead, Kev.
If you recall, the State Auditor's Office, Treasurer's Office, LSO, and the State Budget Department collaborated heavily to improve the estimate for revenue for tobacco funds. Late in our conversation last year, it was really close whether or not we thought we had enough money in the tobacco funds or not. And we picked on, or we actually reached out to the Department of Health and said, can you give us some assistance and allow us to reduce that and look at our revenue? They volunteered that up politely. We worked that with you in the Joint Appropriations Committee. And now with the time that has passed and the process that we have put in place on tobacco funds, 2 things. 1, we want to thank the Department of Health for volunteering to assist us. And number 2, the estimate that we have for, and everybody agrees upon, will cover this tobacco funds. And then lastly, as we proceed, each biennium, we'll have that same report. We'll all mutually agree about the tobacco funds, and you will receive either reductions to across the agencies for the tobacco funds, or you'll receive, yes, we are confident that we can cover these expenditures with tobacco funds in the future.
Mr. Chairman.
Go ahead.
Thank you. So Kevin, my memory has it that we figured we had about $1.2 million of tobacco funds left to move forward with. And so my question is just to update me on numbers, because when I read this, I was concerned that if we're reverting back to those tobacco fund dollars, do we indeed have enough there to carry this forward? This first round is about over 2 million, about 2.1. So just update me when you say we have enough doing that. Help me understand what that is, and are we okay?
Yes, we are. We have $5 million now identified, and we're asking for that $2,097,183, I believe, in tobacco. Excuse me.
Yeah.
No, the first 2, the item number 1, yes. So yes, we are good. But
And
more importantly, the process that LSO, the State Treasurer's Office, the State Auditor's Office, the State Budget Department that we put in place now is really more significant, more accurate, more agreed upon than it has ever been. So yes.
And follow up, Mr. Chairman, and because I really do appreciate the accuracy of that. And then I would make the assumption of just like confirmation that you, because as you put this together, you've looked at all of the other appropriations for tobacco funds that may be coming back in the step 2 and step 3 too. I think we had some.
Yeah, they're small amounts scattered across, but more importantly is you will not receive a budget from the state budget department or the agencies that we do not have confidence in that we can cover with the tobacco funds in the future.
Thank you.
Mr. Chair.
Yeah, go ahead. Representative Schwartz.
Kevin, so I heard you say that it was a total of $5.9 million in tobacco funds that this 2.1 was part of. Is that correct?
Yes, so we'll still have $3 million and change left to start 23-24. And then naturally, as we collect information and reversions, all that will improve when we get to 23-24. But guaranteed, we will have this fully reconciled before we submit a budget for 23-24 with the new process. So we're not where we were in the past.
Kevin, just remind us, what's the balance in that account and what's the annual refeed that we receive, or if any?
Mr. Chairman, we can provide that information to you, and even LSO has it as agreed upon. They can share that with you.
Don?
Mr. Chairman, I think it's about $85 million is in the corpus, and we continue to receive master settlement payments approximately equal to $15 million annually, $30 million for the biennium. And then we generate interest income. And that's the one that is fairly volatile, unfortunately, is the interest income. But I think our estimates are roughly $2 million a year. And I'm rounding here.
And those are, Don, are those in the tobacco funds, are they in the Pool A or where are they located?
Mr. Chairman, they are invested by the state treasurer in Pool A.
And has there been a desire to move that, kind of spread that around or do anything with it?
No, Mr. Chairman, I think Pool A is the more aggressive pool. So that's the statutory savings of permanent funds. So it is invested in part in equities and other investments that are not fixed income related.
Okay, go ahead.
Don would remind me also that so that's a statutory corpus, and okay, so it is, and then, but we're just using the revenue generated off from it. And if memory serves me correct, you told me that we're one of the few states that really done this. The others have just expended the funds that they've come in, and we've been using that to generate revenue to fund projects. Is that right?
Mr. Chairman, that's correct. The first few biennia, the state of Wyoming built up that $85 million corpus by investing those master settlement payments rather than using them for ongoing appropriations. Wyoming had to depart from that method, and now we use the master settlement payments as income to support the activities of the Department of Family Services, AG, Department of Corrections, and Department of Health. Most states did not initiate that creation of a endowment, if you will, in the early years of the settlement.
Thank you.
Mr. Chair?
Go ahead.
Just real quick, Don, what's the account number for that?
Mr. Chairman, I'll have to get that for you. I don't have it off the top of my head.
It's not that important, Don.
All right, go ahead. I'm
You're
not
muted,
hearing you.
Stefan.
Pardon me, Mr. Chairman. I have all this Zoom experience, and this still happens frequently. If there's no other questions on the tobacco fund exception request, we'll move to the final two exception requests that you all in the Joint Appropriations Committee see every year. And the first one is related to our developmental preschool child count. We always have a placeholder exception request every year in the budget book based on if the child count at our preschool programs would increase. And then we monitor it because the count comes in on December 1st every year. And we always come to this hearing with an adjusted figure, either up or down. And for this year's child count, I will mention this, you can cross this exception request off your list. The child count did not increase in either the Part C program, which is birth to 2 years old, or the Part B program, which is 3 to 5 years old. So typically this has happened a couple of times over the past several years where the child count has gone down, and we just scratch this one off our list. The funding in this program is statutorily mandated at a per child amount. So any unused funds in this program always just revert at the end of the biennium. So
Stephen, didn't we have discussions about this, that in order to do our maintenance effort, we can't go lower, but can we reduce it down if the numbers actually go down?
Mr. Chairman, good question and a big can of worms, but happy to address it. Yes, so there are maintenance of effort requirements with the federal government and the Department of Education in both of these programs. So again, the birth to 2-year-olds and the 3 to 5-year-olds. There are exceptions to maintenance of effort for example, when the child count goes down, or some others that we can get into when we discuss this unit in particular. But yes, we do have to maintain maintenance of effort to continue to receive our federal funds. Currently, this program is approximately, I believe, $71 million total. 68 million of that is state general funds. So again, to Senator Kinski's point about mental health and substance abuse, this is another heavily weighted general fund program in the grand scheme of things. But we'll talk about our maintenance of effort issues, especially Representative Chairman Nicholas, when we talk about the Step 2 budget reductions and any estimated or forecasted maintenance of effort and federal fund impacts.
Okay, go ahead.
The last exception request, Mr. Chairman, is what we call the external cost adjustment. Per statute and per guidance from the LSO, each year we are required to bring an exception request to the legislature for any external cost adjustment that would have been implemented in the education system, and this would apply to the developmental preschools as well. And we're directed per law to bring all accumulated external cost adjustments from previous years that were not funded. So you'll see here the external cost adjustment request for the preschools is just north of $8 million. I will mention to the committee that in previous years, this committee and the legislature have sometimes authorized ECAs, portions of the ECA, or denied them. It really has just depended on the year. In this particular budget, you'll see the governor's recommendation here is not to fund the external cost adjustment, but just wanted to point out we are required to bring this to you each budget.
Proceed.
Okay, thank you, Mr. Chairman. We'll move now to starting on page 53, the bottom of page 53, our Step 2 reductions. And I just want to go over these. We won't hit each one, but this will be a nice cue up to our more detailed discussion through the budget book as we hit all of these units. I'd mentioned, Mr. Chairman, that all of what you see in Step 2 is our priority number 1. With a few exceptions, these are basically administrative reductions, things like 200 series eliminations, support services, things that we can try to live without in many of these different program areas. But I did want, and those priority number 1s, with one exception, total about $2.7 million in basically administrative reductions. But it also includes, as you'll notice on page 54, that we have a $20 million general fund reduction that's also in our priority number 1. And I wanted to mention it because it seems so out of whack in this, where you see some of these smaller admin reductions and then a $20 million general fund reduction here. To remind the committee, years ago in the 17-18 biennium, when we made substantial cuts to the Department of Health, we did cut many different areas and reduced services and put utilization controls in our Medicaid program. And because of many different factors like federal approval or public comment periods. There were several cuts that just took a while to materialize in the 17-18 biennium. Over the course of the past couple of years, we have seen kind of the intended goal of many of those reductions really take full effect and go to full steam. And that's what you see in this request again the reduction on page 54 in unit 460. It is really essentially we're giving the budget back from some of the utilization that we've seen gone down resulting from previous budget reductions, as well as other exogenous factors with Medicaid in terms of enrollment and lower enrollment in some categories, et cetera. But I wanted to point out in all of these priority ones that we're happy to answer questions about them, but you'll see it's a lot of out-of-state travel, 200 series, things like that. This was one that stands out in our top-ranked priority, and happy to answer any questions there. But otherwise, we can turn to page 57 and dive into some of the more substantial cuts in step 2.
Okay. Any more questions? Proceed.
Turning to page 57, Mr. Chairman, you'll see priority number 7 is the elimination of the Project Out program. This was a kind of a federal, almost like a demonstration project from years ago that really intended to help folks get out of nursing homes and be served in their home and community-based settings. Certainly a program that we fully support in its concept, but the state's investment strategy, for lack of a better term, has really been to continue to invest in our home and community-based service programs for long-term care, which we most certainly have and will keep going here. So this is a program that, again, while good in concept, is one that is certainly optional and a luxury that in times like this we had recommended to cut. So
everyone just heard a little background noise, which was a helicopter. And from my window here, I can watch the helicopter take off as I'm listening to it from Mike's seat. Okay, go ahead.
Mr. Chairman, that was right outside my window as well. So if that happens again, happy to reiterate anything. Also on page 57, members of the committee, you'll see priority number 8 is really a change to how we reimburse behavioral health therapies in Medicaid. And essentially this is a coding update really to match national standard coding guidelines. And instead of paying for 15-minute units, which as you know can encourage additional utilization, we will now pay for behavioral health therapies basically on a per session basis, and we estimate some general fund savings out of that.
Chairman.
Go ahead.
So Stefan, on that, correct me, and then we limit the number of sessions because that had been a little bit of the problem with the 15-minute thing, as well as they got repetitive. And I think with this change, you also limit the number of sessions per day. Is that correct?
Mr. Chairman, you're right. That change that you're talking about is in a subsequent cut that we will also talk about. But yes, your point is valid. Mr. Chairman, turning to page 58, I wanted to point out our priority.
Mr. Chairman.
Mr. Chairman, it looks like there's a question.
Yeah, go ahead.
Thank you, Mr. Chairman. So I might as well bring up this question now. It's related to the Project Out, because elsewhere in the budget, you've cut programs that were designed to keep people out of nursing homes. And it's just an example of, I get concerned that we're not looking at the collateral costs that can be incurred if we're not keeping people out of nursing homes. A certain percentage of them, I'm assuming, will wind up in nursing homes on Medicaid. Have you done these calculations? And it's not just with nursing homes. In general, with your cuts, that's a potential.
Mr. Chairman, Representative Schwartz, it's a good point and a fair point. We did incorporate that into all of our budget reduction discussions and our calculations to account for, in some of these program eliminations or program reductions, what we might anticipate seeing on the nursing home side. And obviously it's a concern to the department as well, where we've been beating the drum about our long-term care issues in the state for a number of years. And certainly our strategy is to invest and focus as much as we can on home-based services. We feel like even with this difficult budget reduction, we can continue to do that through our waiver programs. And hopefully, as our Medicaid administrator, Terry Green, could elaborate on, in our step 2 and our step 3 reductions, depending on how they shake out, we are also looking to try to make many provider groups whole through the use of what we call upper payment limit programs and things of that nature. But Representative Schwartz, it's a good point, and it's something that we're certainly concerned about, but we do think that the state's and the department's best policy and investment strategy would be to continue to maintain what we have with our long-term care waiver, because that does seem to be one of the most effective vehicles for keeping people out of and getting people out of more facility-based settings.
Thank you. I mean, I'm partially satisfied. I guess I will just keep listening to descriptions. But just, I mean, in my mind, I was assuming that for every person that goes to a nursing home, ballpark $45,000 of general fund to support Medicaid if they wind up on Medicaid. Is that about right?
Mr. Chairman, Representative Schwartz, yeah, that's in the ballpark. We see the waiver services, so the home and community-based services, cost about 40% on an annual or biennial basis than nursing home reimbursements.
Great, thank you very much, Stephen.
Mr. Chairman, moving on, again, page 58, you'll see our priority number 9. It's worth pointing out to the committee, this is really the result of your and the legislature's action. We are able to make this reduction in our children's health insurance program, what we call CHIP, because we have brought that program to in-house administration. For a variety of reasons, including federal rules related to managed care. This was the first year that we had not received a bid. Typically, this program was awarded to Blue Cross Blue Shield of Wyoming and operated basically in kind of a managed care framework. Having to bring it in-house because we did not receive a bid this year, it does result in significant administrative savings. Going back to what I mentioned before, again, the department's Medicaid program does operate quite efficiently when you look at the service expenditures versus the administrative and staffing costs, and that's something that we can leverage here. So happy to answer any questions or defer to Terry Green, who I know is on the line as well. Okay, moving on, Mr. Chairman, also page 58, you will see Representative Larson, I believe this was your question on priority 11. This would eliminate, excuse me, this is not related to Representative Larson, this is another area, but priority 11 is eliminating some services in our developmental disability waiver programs, such as physical therapy, occupational therapy, speech therapy, that are also provided through the state plan. To refresh the committee's memory, our waiver clients are also eligible for traditional Medicaid, so basically the medical benefit in addition to waiver services. And this cut would essentially eliminate those services being available as part of the waiver individual budget calculation. And instead, the services would be accessed through the state plan. This does result in some efficiencies just by nature of how the services are delivered and billed on a fee-for-service basis.
Mr. Chairman.
Go ahead.
So, Stephen, let's just walk through that a little bit, and then the question is, how do we address because there are some impacts that we can't really get around if I understand our conversation correctly. So we put a cap. The waivers you could get all of these OT, PTs, this stuff just as part of, as long as it stayed within your individual budget amount. And now we're saying we're going to put a cap on those types of services. And then after that, they can get them through Medicaid. They can basically as needed per a doctor's order. The challenge, if I understand it correctly, is then Medicaid reimburses for to rehabilitate. What's the right word there, Stephen?
Yeah, a good question, Mr. Chairman and Representative Larson. It's the difference between what we call rehabilitative services and habilitative services.
And habilitative or maintenance. And so if you've got somebody that's been on the waiver for a long time, and they perhaps, let's just say, getting speech therapy, not for speech, but to help them swallow, that would then be considered maintenance or habilitative, and then would not be covered by the Medicaid services. And so in this effort, in this, hats off to the department. In this effort, we still are going to have a gap that, for example, if you've got somebody on the DD waiver that is very acute and needs physical therapy, and they do that therapy to try and keep some mobility, and if they don't get that, then they become constricted, and you couldn't do that maintenance. You'd have to wait and then get a prescription to do some rehabilitative, which seems like you're taking a step backwards. And so my question then is, what's the plan to address that? Because I think that that's a critical concern for our community providers and for families that have these people that may not get those types of services, even though the attempt is to provide as much as we can.
Mr. Chairman, Representative Larson, you're absolutely right. That distinction between how the service is offered, like you said, if it was a habilitative or maintenance service that was previously covered under the waiver and now would not be, it would essentially not be covered. And then if a client or a member lost mobility or essentially reverted back and then needed a rehabilitative service, then that would be covered under the state plan. But we have been, and our waiver staff have already been working with case managers and clients to essentially do what you're talking about, to bridge the gap as much as we're able with a change like this, noting that, again, when we start to get lower in our priority list here, none of my answers are going to be very easy for the committee because the impacts are so real. But I'll certainly defer Representative Larson and Mr. Chairman, if I may, if Terry Green or any of her staff have additional elements to offer there.
Stefan, there's obviously going to be some educational components to the providers where they have to be cognizant of this and pay attention, because otherwise it'll be the only way we can close that loophole is just proper billing.
Mr. Chairman, absolutely, and that process has begun months ago when step 2 was approved by the governor.
So follow up, Mr. Chairman, on that. And then the other part of that challenge that I hear back, I think that there's two components of that. One is going to the Medicaid model then and then requiring an approval of additional service really is another check and balance in there to make sure that we're proper use of state general funds. But the second part of that is it's another burden on the provider to make the request. It's paperwork. And with our history with some of our contractors that oversee in Medicaid, thank heavens we have Terry Green on board, but because we had some trouble, and this committee will recall up in Sheridan some problems getting some stuff done, and it really kind of come back to getting this stuff approved in a timely manner. And so you sense us all taking a deep breath because time is of the essence on this. And so are you working on a plan to ensure that?
Mr. Chairman, Representative Larson, the short and easy answer is yes. But the more realistic answer is, again, these cuts, if approved and implemented, they just do have these material impacts. So there will be services that won't be received or won't be received in the same way they were prior.
Thank you. Thanks, Mr. Chairman.
Mr. Chairman, moving on, also on page 58, we do have a program reduction. This is kind of a combination of a program reduction and a contracted service. We calculated it in your summary as a program reduction, but it really does operate through contract. This is some reductions and reduced activities with some of the areas that Representative Larson was just mentioning. So we have a health management contractor in our Medicaid program that does things like wellness and reaching out to various types of Medicaid clients to let them know services that are available or help manage chronic conditions. In a time like this, we do have to reduce a service like that. In addition, that contractor also oversees some utilization management functions, which we will also reduce expenditures there. We're confident, Mr. Chairman and members of the committee, that this reduction in utilization management will not result in great utilization increases. Again, going back to my previous comments, we have been successful as a department and an agency in keeping our growth in Medicaid expenditures well under control, especially compared to other states, and we intend to keep that going. So this is really a contracted service reduction to that health management and utilization management program. Moving on to page 59, Mr. Chairman, three cuts I'd like to point out here in step 2. Priority number 18 is the elimination of what we call the PACE program. This is Program for All-Inclusive Care of the Elderly. It's basically a demonstration project, pilot project years and years ago that the federal government made available. Wyoming elected to authorize us to administer this program, but it has only been in Laramie County here in Cheyenne. It has been operated by our local hospital here and serves about 130 clients in just a different kind of care for elderly. Again, same kind of intent as our long-term care waiver or other programs to keep folks in the community, keep folks at home as opposed to a nursing home. But again, this program, we are electing to eliminate. Again, geographically, it's a bit inequitable where no other community in the state of Wyoming has it, and we also have the long-term care waiver services that are available to all of these clients who qualify for this type of care. So that is a program elimination, and it will be, there's a federally required phase-out period, which we are in right now.
Mr. Chair. Mr. Chairman.
Go ahead, Representative Simpson.
Thank you, Mr. Chairman. Sorry, Mr. Johansson, I need you to go back to priority number 12 for me, please.
Yes, sir.
You're eliminating the chiropractic benefit. Chiropractors are telling me that by pulling them and single-handedly getting them off of the Medicaid program, that Medicaid patients that come to them are now going to have to go to ERs and will significantly increase the cost of the Medicaid program. Could you address that of why the chiropractors are being pulled out of the system?
Mr. Chairman, Representative Simpson's a great question. Just as a little bit of background for the committee, this benefit in the Medicaid program was authorized very recently by the legislature as a covered benefit under Medicaid, I believe 2 years ago, if memory serves. You can see by the dollar amount there that it is not a heavily utilized service, and this is an optional service under federal program guidelines for Medicaid. So it's, again, a reluctant cut, like many of these are, that we certainly don't want to eliminate this benefit, but given the choice of do we cut hospitals or nursing homes harder, this was one that just made the list, Representative Simpson. And so it is an eliminated benefit under step 2. When the budget, if the budget situation, the revenue situation in the state were to improve and we have the funding to cover this benefit, we would certainly restore that as it is currently authorized in statute. But no easy way to answer that, sir, quite frankly, is that it's just one of those benefits that's optional, and given the times like this, it made the list for the program elimination.
Stefan, with regards to that, you have that 400,000 budgeted to it. Were you expending all of it, or were you reverting any of it? How many people were being served?
Mr. Chairman, I'd have to get back to you on that or defer to Terry or her staff to see if that, I believe that is the projected expenditure amount that we anticipate essentially getting back as part of this cut. But I was remiss, if I may, Mr. Chairman, I didn't answer the last part of Representative Simpson's question about ER, emergency room utilization. I think what you'll see throughout here is we do put ourselves as a state and as a department at risk with some program reductions and eliminations of seeing either higher levels of care elsewhere or additional emergency room utilization, because that might be where that service could be accessed, if that makes sense. We are certainly managing to that and would do everything to minimize the that potentiality, but it's certainly something that we're monitoring, and I think with the elimination of chiropractics here, or as we get into step 3, you'll see the elimination of adult vision and dental coverage. That's another one where literature suggests you could see some additional emergency room or higher level of care expenditures, but we'll certainly get into those details. And it's a risk that unfortunately with cuts like this, we have to take.
Jesse, did you have some numbers for us?
I did. Chairman Nicholas, Jesse Springer from the Department of Health. The cut is based on actual expenditures. And when this was originally passed, it was passed without an appropriation.
And was there I'm sorry to interrupt, Jesse, was there also was it a once every 4 weeks kind of a restriction to it? I thought there were some type of guidelines for it.
Chairman Nicholas, it was included in the overall service limits prior to prior authorization. So currently it's within the medical area. So it's counted as one of the 20 visits that someone can go get before they require prior authorization. But it could exceed that. If the person was having a mix of medical visits and other care, they could have 40 or 50 visits a year. But the original appropriation didn't add any funding because it assumed there would be savings from adding the benefit, and that has, at least from the research we've done so far, hasn't been the case. It is an additive benefit, and so it's a benefit people use in addition to using other benefits. So generally for pain relief, I would think. So it's like a supplementary benefit to also going to the doctor and other things.
Okay, thank you.
Thank you.
Thank you, Jesse. And Mr. Chairman, moving on page 59, you'll see our priority number 19 is a service limitation for behavioral health on adolescents. This is very similar to what was implemented in the prior round of budget cuts for adults. And as Jesse was just mentioning, it's the same kind of concept. After 30 visits, the client and the services will require prior authorization. So essentially, if you exceed 30 visits under this limitation, a medical provider has to demonstrate what we call in Medicaid medical necessity, that the service is necessary. So it's a bit bureaucratic. It's also a utilization control. We do kind of put these service limitations in place where we see kind of the bulk of the distribution. So we don't eliminate as much as we can, don't eliminate services that are very needed for folks. And it really is, like I said, a bit of a bureaucratic hurdle to demonstrate medical necessity. But you do, through these measures, you do root out some unnecessary utilization, and that's where the savings projections come from.
So I may have missed it, Stephen, but on priority number 16 on court supervised treatment reductions, is that just mimicking actual experience, or do you have a way that you're going to make the courts do that?
Mr. Chairman, we'll get into those details on that unit. I believe I don't want to speak out of the wrong side of my mouth, but that will come when we review the Behavioral Health Division.
All right.
Moving on, Mr. Chairman, priority number 21 on page 59 in our step 2 reductions is the elimination, the phased in elimination of the Wyoming Home Services program. This is what Representative Schwartz was mentioning a few minutes ago. This is a state general fund only program, so it's totally separate from our long-term care waiver that in Medicaid provides home and community-based services to the elderly. This is a general fund program that's been on the books for many years and typically provides at-home services and a lot of care coordination to elderly folks who may not qualify for the Medicaid waiver. It serves as memory, as I recall, about 1,900 eligible members. Again, on a biennial basis, it's about $5.4 million general fund. This is a reluctant elimination of this program that would take effect on July 1st of next year. But again, would go back to my previous comments that in a time like this, we are continuing to focus on our long-term care waiver. That to give you a sense of the scale, this program, $5.4 million for about 1,900 individuals, whereas the long-term care waiver, I believe it's 2,500 or 3,000 individuals and around $114 million biennial spend. So you can see the scale is just where we're putting our resources and our services is much more in one bucket than the other. But no doubt about it, this is a reluctant elimination of a program, and one that if the revenue situation improved, we would be looking to reinstate.
Mr. Chairman.
Go ahead.
Thank you, Mr. Chairman. So I'm curious, do you know what the overlap is here between the number of participants and the number that would be eligible for the long-term care waiver? And let me back that up, because part of my concern is they may not be eligible today for the long-term care waiver, but once they go into a nursing home, it's not unreasonable to expect that it wouldn't take long for them to use their assets and become eligible, which is, in my mind, not a good outcome.
Mr. Chairman, Representative Schwartz, in previous years, we did an analysis, which I'm more than happy to share with the committee, where we looked at, as best we could, the overlap between eligibility in the two programs. It is challenging because this program does not have the same, eligibility restrictions and really, more rules-based eligibility management as our Medicaid program does because of the federal strings attached to it. So different type of assessment. It wasn't really apples to apples, but we did see some overlap. But your point is well taken that, again, similar to some of the other benefits I mentioned that would be removed in these budget cuts, it does put us at somewhat of a risk to see additional nursing home placements. We do think that we can manage through that with other services that are available, either in our communities or through our other programs. But no doubt about it, this is a significant benefit to many folks who receive, some homemaking services or, care management, care coordination, generally operated out of our senior centers. But if our aging division senior administrator Lisa Oswald has anything to add, would certainly welcome that now, Lisa.
Thank you, and I'll stop with that, pursuing that line. I don't think it's going to change. Thank you.
Thank you, Representative. Mr. Chairman.
Thank you, Mr. Chairman. So I was just doing some quick math while we were discussing the two programs. So can you just give me a little more clarification how much federal and how much general fund we're talking about in the two programs? Because you said one was 114 million for 3,000 recipients. So that equates to about $38,000 a year. The other is the 5.4 million for 1,900 members, and that's $28,000 a biennium, excuse me, not a year, but a biennium for those services. So which one is the state getting the best bang for the buck? I'm a little confused on that. Thank you.
Mr. Chairman and Senator Steinmetz, it's a good question, and we'll follow up with you on the breakdown of all, annual and biennial spend for the number of clients that we have in each program. This program, which is the second one you mentioned, the Wyoming Home Services program, it is fully general fund. It's about $5.4 million general fund, and it's operated out of our aging division. The other program that I mentioned, which again is similar in mission or similar in scope, is in our Medicaid division, which is our long-term care waiver. And those expenditures was the 100 or 114 million that I mentioned, and that generally receives a 50% federal match. But I do want to check myself, Senator, and get with our team and make sure that the numbers that we're providing to you on the per person spend on an annual basis, that you have that information. So we'll follow up. We have all of that.
Okay, proceed. Oh, wait, Representative Kenner.
Thank you, Mr. Chairman. Thank you, Stefan. But just to further on along some of those thoughts, so are we to assume then with these folks that there is no alternative for them with this program being cut, that they can't slide into another program and so they're just sort of hanging out there on their own for a while? Or do you see something that could help be a little bit of a parachute for these folks?
Mr. Chairman, Representative Kenner, another good question. Bear with me while I try to answer it. It's a mixed bag. I think it depends on the client. It depends on the service that would be being offered through this program, where there may not be an alternative for one or more of the services for the client. But as was mentioned before, if the individual became eligible for our Medicaid waiver, those services would be provided in a much more comprehensive fashion. But that's not everybody. We all know that. We do have other community-based services through our aging division and through our senior center partners that provide support to folks, including home delivered and congregate meals, as well as other services provided through the senior centers. But I'd be remiss if I didn't say that it's certainly not going to be a one-for-one with an elimination like this.
Go ahead, Senator Kinsky.
Thank you, Mr. Chairman. Stefan, you made reference to the idea that, or at least the hypothesis that these services are keeping people out of the nursing home. And you and I have talked about that. And I know your department was going to take a look at to see whether you could really establish empirically whether that was the case or whether this was simply an additive benefit. And I wonder if you or Lisa Oswald or Jesse Springer might have some data on your look at that.
Mr. Chairman, Senator Kinsky, so a couple of things here. The analysis that you're referring to was really looking at the Medicaid waiver, so not this program for Wyoming Home Services, but the waiver program, which provides home and community-based services. And I believe we shared that analysis with this committee. We're more than happy to resend it. It was a study that I believe was part of House Bill 2 this previous year. We do believe, Senator Kinsky, based on the data and evidence that we have, that we are serving more people in long-term care with the same amount of dollars today than in previous years, partially related to the benefit of the long-term care waiver being there. As you know, it's really difficult to tease out how much induced demand you have since the legislature uncapped the waiver program for long-term care back in 2013. So we do think there's some additive enrollment there, but most certainly offset in what we've seen in the percentage of long-term care members that instead of being served in nursing homes are served in much less expensive home and community-based settings. This program, the Wyoming Home Services program, we have not done a similar type of analysis. Again, it's difficult given the data limitations we have in this program. We do have demographic information and some other data that is useful in this program, but it does not have the same kind of eligibility standards or restrictions that we have in the Medicaid space.
Follow up, Mr. Chairman.
Go ahead.
You made reference to the uncapping in 2013, and I think you said since that time it appears that it might have become more additive. Would it help in controlling costs if it were capped without losing the benefit of postponing people going to long-term care? I'm not sure what the effect of uncapping is, but it sounds like it made the benefit partially more additive than substitutive.
Mr. Chairman, Senator Kinsky, at this time, your Department of Health would recommend leaving that waiver uncapped, given what we've seen in cost offsets in long-term care by nature of serving more individuals at home. And in fact, Wyoming, just in the past 5 years, has gone from serving about 40% of its long-term care Medicaid members in home and community-based settings to over 62% today. That is a demonstrated cost avoidance because all of the clients that are served through the Medicaid long-term care waiver, what we call the Community Choices Waiver, they all qualify and are entitled to nursing home benefits. Now, not everybody would elect to go into a nursing home, but we do see that, that need in the population. And so having these services available in the community, we would still recommend given the complexities with induced demand and the things that you're mentioning, Senator, that this is still a.
Thank you.
Okay. Further questions? Proceed.
Thank you, Mr. Chairman. Moving on to page 60 in your budget book, and we're just about wrapping up with step 2 here. I wanted to point out our priority number 22, which is what we call the YVIP program. This is in public health. This elimination, or this cut, eliminates vaccination funding for private providers. So essentially these vaccines that are typically provided to children, these are covered by private insurance, but this program historically has stocked these vaccines to private providers, and this elimination would remove that from this program. So essentially what we've been doing as part of this cut is working with providers, with the medical society, to not only educate providers, but help as much as we can to assist them in being able to have the vaccines available and also bill for applicable public or private insurance. I believe Stephanie Pyle, our Senior Administrator of Public Health, is on if there's any questions about this particular program and this cut. You will see this program as part of our step 2 and our step 3 budget reductions, but happy to take any questions about that now.
Mr. Chairman.
Go ahead.
Thank you. But the vaccinations, Stephen or Stephanie, it doesn't matter, will still be provided to public health, and individuals could go to public health and still get those vaccinations for free. Is that correct?
Mr. Chairman, I'll defer to Stephanie Pyle. Stephanie, if you're on, and I see a camera on a large conference room, so go ahead.
Mr. Chairman, Stephanie Pyle, the Senior Administrator of the Public Health Division, and Representative Larson, the vaccinations will still be available in public health nursing offices and FQHCs.
Thank you.
You're welcome.
Chairman.
Representative.
Mr. Chairman, thank you. While we're on the topic of vaccinations and public health, I wanted to just sort of ask who the person who would know about sort of the miscommunication that apparently happened between the Sweetwater County Memorial Hospital and the Public Health Department that resulted in none of the Pfizer vaccine being distributed to Southwest Wyoming this week. Obviously, something, I guess that's already happened, but I wanted to find out what we can do in the future to make sure that miscommunications like that don't happen again, I guess.
Mr. Chairman, Representative Stiff, I will also defer that to Stephanie. I know that's being worked through right now in terms of what vaccines will be distributed for COVID-19 all over the state by the end of the month, both from Pfizer and Moderna. That's a evolving situation really by the hour at this point. But Stephanie, anything you'd like to add there?
Sure, Mr. Chairman, Representative Stiff, we have worked through that issue today, and I'd be happy to give you a call after this meeting and give you the details of what transpired.
So what, you don't have to tell us what the why it happened, but how has it been resolved? Are they going to catch up or on the next shipment, or what's the process?
Mr. Chairman, Stephanie Pyle again, yes, they are. And we are preparing a document now that we'll distribute out to all the counties so they can see what their allocations will be. All counties will be receiving distribution by the end of the month.
And with regards to the reservation, is that kind of on separate list, or is that part of the Fremont County list?
Are you just getting it directly?
Mr. Chairman, IHS is receiving that directly.
Okay. Further questions? Proceed.
Thank you, Stephanie, and thank you, Mr. Chairman. We went just about an hour and a half without a COVID-19 question, so thank you for the brief reprieve in all of our lives with that.
Well, before we go on, tell us what arrived. Was it the 5,000 doses? Was it more or less than anticipated? And are they on track?
Mr. Chairman, I'll defer to Stephanie. I believe our first allotment was just under 5,000, and that has been received, I believe, today and tomorrow. But Stephanie, you can address what we anticipate both with Pfizer and Moderna by the end of the month.
Mr. Chairman, thank you for that question. 2 counties, Laramie County and Natrona County, both received 975 doses each. 3 additional counties will receive their doses tomorrow. and we expect for administration of those vaccines to begin tomorrow. Following that, if the Moderna vaccine is authorized, those shipments will go out and be received by counties next week. And we have a tentative plan that by the end of the month, approximately 27,000 doses will be completed based on the tentative numbers that we have from the CDC right now.
Okay, thank you.
Thank you, Stephanie, and thank you, Mr. Chairman. Moving on page 60, priority number 23, you will see a reduction in slots on our comprehensive waiver, which is a developmental disability waiver. And essentially, we will add corresponding slots to the support waiver on a one-for-one basis. So that, as you know, the supports waiver does not, as the name would suggest, does not provide as comprehensive benefits as the comprehensive waiver. And so this is kind of a shifting of waitlist priorities and adding slots to the supports waiver while reducing them on the comprehensive waiver.
And Stefan, my understanding is that on some of those support waivers that you've also reduced the how much you pay for certain amounts of procedures or time, which results in a fairly substantial cut in some providers' benefits. So could you flesh that out for me a little bit, please? Or you can do that when we get to it.
Mr. Chairman, I probably recommend doing that when we get to that unit, but I'm happy to have Terry or Jesse elaborate now if you'd like.
Mr. Chairman.
Go ahead.
Thank you. So, Stefan, the way I recall this was we had a certain number of slots on the comprehensive waiver. And if we had some, and those comprehensive, that if it was for me, I would have that individual amount till I died. And then when I died, that amount then would allow somebody else to come on a comprehensive waiver. It was kind of the way we had that designed, and we, the so-called waiting list that's out there. And we designed that in our waiver redesign a number of years ago. We brought on the support waivers, but we still had a mechanism if people were acute to put them on a comprehensive waiver and adjust that IBA. And so now we're going to take those as they become available. Those funds will put people on the support waivers, but not on the comprehensive waiver. Is that correct?
Mr. Chairman, Representative Larson, yes, in general, that's correct. I will, again, if we want to discuss now, happy to do so, defer to Terry or Jesse at our Division of Healthcare Financing.
So, and just let me follow up a little bit with that, and then we can maybe get into that a little more, because then what we have found historically on the support waivers, because there aren't quite as many services given to the individual, that one of the mechanisms available then to perhaps increase a person's individual amount and put them on comprehensive waiver was that ECC, Emergency Something Committee, whatever you guys call it, or EEC. But that now becomes much more difficult. And so in essence, and it's just important, I think, for all of us to understand, is the ability to get expanded services for the DD or ID population on the waivers we're being forced to restrict that through these actions, correct?
Mr. Chairman, Representative Larson, I'll defer to Jesse Springer on that. I see him on my screen and much more informed on this than me.
Chairman Nicholas, Representative Larson. So when we originally did Medicaid reform, gosh, it's been like 2013 now. One of the ideas of that was as it created the comp waiver, and as people left the comp waiver for whatever reason, you could either replace one person on the comp waiver or sometimes multiple people, because the previous funding levels were very high relative to the new waivers. Or you could transition that slot to the support waiver. And in that case, sometimes you could fund 2 or 3 or sometimes more people, given the differences of the funding. So this particular reduction, instead of replacing 1-to-1 on the comp waiver or 1-to-2, between the comp and the support, this is actually just saying we're going to keep serving the same amount of people, but the new people coming on are going to have less service. And that's basically how this one-to-one works, is that you're gaining like $40,000 to $50,000 of savings a year for every person who transitions between the comp and the support, given the different funding levels of those programs. And you did describe it accurately with some of the changes to the Extraordinary Care Committee. That's been a mechanism that people have used to appeal and have different budget levels over time. And over time, if those continue to be approved, people could originally come on the program at 50,000, but end up at 120,000, but their actual assessed level of need is 50,000. And so over time, that can cause budget creep. And so that's where some of these, there's a number of cuts here that basically talk about actually putting people in at their assessed need. So there's a number of these work together to achieve the savings. I don't know if that answered the question or not.
I'm good. Thank you.
So just to follow up on that, I'm just curious what that turns into percentage-wise as an overall impact to the providers and what they can reasonably anticipate in cuts in their budget. Is it 5%? Is it 7.5%? Is it 10%? Obviously in part, it depends on who goes off and who comes on. And so it's kind of the luck of the draw, but have you made those calculations?
Chairman Nicholas, basically every dollar that's coming out of here will be coming out of some provider's pocket. So whether they'll have the cost of delivering that service, so it's not all just a loss of, they're losing revenue, but they had a cost of delivering that service in some cases. But yeah, within these comprehensive and support waiver reductions, there's a 2.5% rate reduction, and that'll hit basically every provider. And then some of these shifts will have disparate impact. So some providers may experience them more severely if they had someone on the comp waiver, where some providers may have no impact at all. It just depends on the shifts over time, because this is not taking any live human being and shifting them between a program. They're only taking new people and shifting. So it's just very hard to predict where those people are on wait lists and all sorts of things. We could follow up with additional information on expected provider impacts.
Yeah, Jesse, I guess that's my point, is that what I'm curious about is if on some providers, if they have the right particular type of clientele, it could be a draconian cut, whereas it might be no cuts to someone else. And so understanding who those folks are and how much it will be, I think if you have not made that assessment, it should be not too difficult to do, I presume, at least the providers ought to be able to figure it out. But I just want to know if we're going to be shutting people down as a result of this, or individual providers that are out there.
Chairman Nicholas, I think we understand the request and we'll follow up.
Thank you.
Thank you.
Mr. Chairman.
Go ahead.
Go ahead.
So this is a question for Stefan or for Jesse Springer. And Stefan, on September 22nd, my birthday, I might add, you sent me a memo with WDH responses to budget reduction questions, and you attached the annual expenditure for various types of providers. And so I don't know what kind of provider we're talking about in this context with respect to the questions that Chairman Nicholas has. Would this be day training, developmentally disabled service, 251C00000X?
Mr. Chairman, Senator Kinski, I always like to send you these types of memos on your birthday, so I'll keep that going in future years. That would be an example of one of them, yes. And Jesse, you could probably clarify. But again, this is a little bit of a heavy lift, but we'll touch base, Chairman Nicholas and Senator Kinski, to flesh out that analysis and build on the document, Senator, that you're referring to.
Well, and Mr. Chairman, if I may.
Sure.
if you could just group the various providers that are likely to be impacted. And the reason I'm asking, and as you know, I've been pressing you pretty hard on this DD waiver. It's a big number. This one code alone, day training, development disabled service, is $113 million per year. I mean, there's a lot of money that goes into this program. So that leads to my second question. Why on priority 23 did you limit this just to new clients? Could you apply it to any client? Could you apply it to clients already on service so that somebody who comes on with a $50,000 need and is now at a $120,000 need goes back to a $50,000 budget? Can you do that to people already in the program? And if so, what would that save? If you know.
And Mr. Chairman, Senator Kinski, I'll have Jesse, back me up or correct me if I'm wrong here. The concept that you're talking about is flushed out in our step 3 reductions as a kind of budget equalization methodology for the waiver clients. So that's not exactly what you're referring to, but I think the concept is the same.
Thank you. Thank you, Mr. Chairman.
Chairman Nicholas, Senator Kinski, I think Stefan addressed it. It's really one of the listed reductions. So thanks.
Okay.
Moving on, Mr. Chairman, and we're just about done with step 2 here. Step 3 might not take as long to go through, so appreciate the overview. I think it will expedite our page turn with the budget. Also on page 60, you'll see priority 24 is a reduction to the early intervention education program, also known as our developmental preschool program. This was across Part B and Part C, a total of $8.8 million of reductions. You will see in step 3, kind of corresponding to this, that the governor's recommendation has been to backfill part of this cut with school foundation funds. And we'll talk about that when we get to the unit. So the effective cut here will look a little bit different if you were to approve step 3. But for the time being, the cut proposal in step 2 is around $8.8 million to these preschool programs.
And so I'm just curious, Kevin, is that because of our abundance of funds we have on the school side?
Mr. Chairman, what it's for is to give us some time, and particularly the legislature, the option to review this in full. But what really comes down to is the MOE requirement from the Department of Education for the loss of these funds. That conversation needs to be had. I think also staff has information on the chances of having a violation of MOE, but that's why we extended this, so that we could review the exposure or the chance that we would have a run-in with an MOE on the Department of Ed side, and we decided to use the Department of Education savings that we had from ETS.
Okay.
Thank you, Kevin. And Mr. Chairman, the last reduction here that I'll mention, and it's happy to stand for any questions. Priority number 25, and bear with me, that helicopter is just right outside my window. Priority number 25 is the 2.5% reimbursement rate reduction that Jesse mentioned before, really for most provider types. This is basically an across-the-board reduction in Medicaid reimbursement rates. Some providers will not see this, and those are basically the ones that have federally set rates. So federally qualified health centers, this won't apply to the Life Resource Center. That would, cut off our nose to spite our face, because that would all be made up with general fund anyways. But this is a 2.5% reduction to most Medicaid provider types. So hospitals, clinics, nursing homes, waiver providers, it really is across the board. And you can see at that level of reduction, we achieve approximately $11.3 million of general fund savings. And finally, Mr. Chairman, the priorities 26, 27, and 28, I had mentioned before. 26 and 27 are really, again, capturing some additional federal funds that we have that we had talked about in our introduction and overview, both in terms of money that goes to providers that we are offsetting general fund because we had additional federal funds because of that match bump, as well as if you look at number 27, that's a very complicated program, but essentially it's a It's a program that we use to give additional revenue to certain provider types by essentially assessing a fee on them and then drawing down more federal match and redistributing it to providers. Again, because of the 6.2% match increase, we can leverage some additional funds here. So you'll see the offsets in both of those areas related to the match increase. And then finally, priority number 28 was what I had mentioned before in the per diem reduction, the reimbursement rate reduction to Title 25 providers going from 677 a day to 610. So, Mr. Chairman, I'm happy to stand for any questions on step 2. We can go over step 3, but I'll leave it to your discretion in the committee on if we should take questions now or just plow on through. We're ready to do either.
So do you want to do the quick synopsis of step 3 first before we break, or do you want to after break? Which one, Stephen?
Mr. Chairman, can do whatever. I could budget in. I believe we could go over step 3 in maybe 20 minutes, depending on the questions. There are some significant cuts here that will generate some questions. But again, as we get into the page turn of the budget, I think being able to see step 2 and step 3 within one unit might be easy to answer the questions then.
All right, with that, we'll take a break. We'll be back in 10 minutes. We'll be back at 3:10.
Who are we waiting on? You're muted, Bob.
Okay, sorry, we're waiting on me because I was typing emails. All right, let's proceed.
Thank you, Mr. Chairman, members of the committee. We'll dive right in here in a second. I did want to mention to the committee, per Senator Steinmetz's question about some of the numbers on long-term care. We do share with this committee and others in the legislature. Every year we have an annual report, basically. We call it Health Stat. It's performance reporting on all of our programs. So Senator Steinmetz, I did pull up the long-term care summary for both our waiver programs, our nursing homes, et cetera. We'll be shooting that to you following this hearing. But I did want to mention to the committee that it is a good resource. We put a new one out generally every January that has a full listing of all of our programs, a snapshot with all of the fiscal information, in a performance report with all of the outcomes and the targets that we're trying to hit. So we'll certainly send the most recent copy to the committee, but we will also be putting out our fiscal year 2020 reports probably in January. So wanted to mention that. And then before we dive into step 3, Mr. Chairman, I was completely reluctant to provide a little bit of gratitude and thanks to our staff, as Director Schmidt did with DFS. Given this year that we've all been through, the step 2 and the step 3 budget reductions, preparing that was a Herculean task. And I just want to thank all of our senior administrators, Terry Green, Matt Petrie, Lisa Oswald, certainly our CFO, Eric McVicker, and a special thanks to Stephanie Pyle. You know, her plate, as many of ours, has been very full with managing the pandemic, in addition to what we're having to do, unfortunately, with our budget. So just wanted to provide some thanks and gratitude for all of the staff in the department for helping us get this together. So without any further ado, we'll move on to our step 3 budget reduction overview. It begins on page 62 of your budget book. But Mr. Chairman, I might recommend from page 62 to page 69 is really similar to our step 2 reductions. Quite a few more minor administrative support service type reductions. And obviously, when we get to those units, we will be able to answer any questions the committee has. But the more substantive program and policy decisions in step 3 really start on page 69 with priority 7. But Mr. Chairman, we can certainly go through each one if it's your preference.
So, well, let's just do this real quickly. Let's just, the process you started, Stefan, but let's just go, let's try not to ask too many questions other than the big ones, and so that we can have a target be done by 5.
Thank you, Mr. Chairman. If you'll flip to page 69, priority number 7, there's 2 reductions in priority number 7 that are very substantial. This first one is the elimination of the children's mental health waiver. And again, it's worth noting to the committee to bear in mind these step 3 reductions, as you know, are proposals that under the governor's recommendation, if approved, would begin to take effect July 1st of next year of 2021. But on page 69, priority number 7 is the elimination of the children's mental health waiver. That is a waiver program that's basically provides behavioral health services to children in need, kind of above and beyond what traditional Medicaid would offer, both in terms of wraparound services as well as additional eligibility for folks who might not qualify for Medicaid based on their family income. Where this savings comes from, as you'll see in the description, and we'll get into the detail when we get to the budget unit, about 55 children we estimate who are currently on the children's mental health waiver. If it were eliminated, they would not qualify for traditional Medicaid because of their family income being above the eligibility threshold. That's where this savings comes from. And the second priority 7, which is on page 70, kind of goes hand in hand with that cut. and that's the elimination of what we call the care management entity, which goes hand in hand with the mental health waiver. Essentially, it's a vendor, almost like a managed care vendor that provides wraparound services, care coordination, case management, and also enrolls providers in this network for the mental health waiver. So these two cuts, again, these are substantial. These are reluctant cuts, as many of our step 3 reductions are that you'll see, and certainly has a material impact on the people who receive these services. We did communicate with the Department of Family Services, Director Schmidt and her staff, obviously with some of the children and families that they provide services to. There's some overlap here. And so I think from Family Services perspective, this is also quite a concerning reduction. Again, I'll just play the role of Scrooge here in the month of December and present all of these to you, but I hope you know these are not easy decisions for the department. So priority number 7 is 2 kind of concurrent cuts with eliminating the waiver, which is an optional service, and then eliminating the kind of wraparound vendor services that go on top of that for those children. The children who qualify for traditional Medicaid would still be able to receive.
So one second, Vice Chair.
Thank you, Stephen. Is this the same?
Stephen, how many people in this division, how many people administer this program in the Department of Health do you have working in this area?
Mr. Chairman, Senator Hicks, I'll have to follow up with you on that. I believe it's less than an FTE, but we'll follow up.
All right, thank you.
Mr. Chairman.
Go ahead.
Thank you. Stephen, is this the same contract for the community mental or the children's mental health waiver as it is for the step 2 wraparound services we've seen there in Unit 401?
Mr. Chairman, I don't believe so. In step 2, which reduction were you referring to?
On page 58, the reduced activities, health utilization management.
Mr. Chairman, Representative Larson, no, that would be a different program altogether.
Thank you.
Okay.
Stefan, you're muted.
Okay, sorry, I was struggling with the mute button again. On page 70.
We were enjoying the silence, Stefan.
I'm sure I was enjoying it more than you were. Page 70, priority number 8 is the additional cut to the Wyoming Vaccinates Important People, or WYVIP program. You'll see in the description when we get to that unit, as Stephanie Pyle mentioned earlier, the full effect of these 2 cuts in step 2 and step 3 would be essentially these vaccines only being provided to public health nurses' offices and federally qualified health centers. We'll be happy to provide additional detail or answer questions if you have them when we get to that unit. Moving to page 71, Mr. Chairman, these priority number 10, there are 4 of them. That's because this all relates to our community mental health and substance abuse units. So unit 2506, 07, 08, and 09, that's all of our community mental health outpatient and residential and community substance abuse outpatient and residential services. These are funded via contract. This would total, I believe, about 15.2 million in the reduction to those units. So it represents about a 16% reduction to the community mental health and substance abuse centers. As you'll remember in step 2, this was an overt effort, as Director Ceballos mentioned, to protect the behavioral health continuum, knowing that that's a need in this state. So you saw very minimal cuts to this system in step 2. But again, in step 3, it's just at these cut levels, it's difficult not to, again, hit those top 5 program areas that represent so much of our general fund. So this would be a significant cut to the community mental health and substance abuse contracts. And I know that system is in the process with your committee and the Joint Labor Committee looking at reforms to that system, looking at prioritizing those dollars to certain types of populations, and maybe moving away from general access to more of a prioritized system. And the discussion at that committee, this one and joint labor, has been, is that a necessity in this type of budget climate where we know cuts like this might have to be made in the future? Mr. Chairman, page 74 is priority number 13, which is what Representative Larson was mentioning a few minutes ago prior to the break. Under priority 13, we would essentially freeze requests for increased funding on the waiver, the developmental disability waiver, for what we call the Extraordinary Care Committee. And that's a process by which individuals on the waiver, their case managers, can request basically emergency or extraordinary care funding above and beyond their budget amount that was set for a variety of reasons or circumstances. And we would freeze this and, as you can see, achieve approximately $1.8 million in biennial savings.
Mr. Chairman.
Go ahead, Lloyd.
So thank you. So Stefan, is that come hell or high water, that's just the way it's going to be? Your IBA is your IBA? Or because what we found in the past is there are times when the assessment has been deemed to be incorrect. And so we've come before the ECC and readjusted that, not to give them one time, but to readjust their actual waiver, their IBA. And so just give me it is what it is, and if there's mistakes made, tough rock goes, or what?
Mr. Chairman, Representative Larson, as with so many government services, I think there would still be an opportunity to appeal decisions. That might be related just to the general budget or decision making there. But I'll let Jesse speak to the specifics around extraordinary care freeze that would happen here, and how much of it is kind of final decision versus some sort of appeal process. Jesse?
Chairman Nicholas, Representative Larson, this reduction is actually to limit the scope of what that committee would be able to do. And the reduction of that authority would be to review the level of care assessments and make sure they were accurate. So I don't think we're suggesting that we wouldn't have that opportunity for clients to make sure their level of care assessment, if they said, this just isn't accurate, this isn't enough service for my level of care, they would have those assessments and be able to take those to the Extraordinary Care Committee. What this committee is able to do right now is add on significant levels of funding within their authority. So that could lead, in some cases, to emergency funding being added. And what's been the case in the past is that emergency funding becomes long-term funding. And that's been, worked on over the years, but that was the case when we went through Medicaid reform, and then that's been tightened up over the years. But this specific reduction is to actually limit, again, the authority of that committee to make sure that the service plans are accurate, but not to be able to do other actions.
Okay, thank you.
Mr. Chairman, happy to continue. I do see some hands up in the gallery here.
Okay, Senator Steinmetz.
Thank you, Mr. Chairman. As we're going through this and I'm seeing all the programs that we're cutting and all of the money that we're saving the state of Wyoming, we thank you for that. What I was thinking might be very helpful for the committee is an organizational chart that would show us how this affects your agency. And so when we make these cuts, we'd know kind of how many personnel we're dealing with, how many are still administering, how much funding is still left, and we could have that organizational chart to kind of compare that and see if our staffing levels are still correct. So could you provide that for us and that information? Thank you, Mr. Chairman.
Mr. Chairman, Senator Steinmetz, happy to work on that. If it's okay, would like to follow up with you directly on what would be best to see. There is a lot of overlap in our department. For example, in our healthcare financing division, which manages about $1.4 billion of programming, we have just north of 100 staff there, and they do a lot of different management, not necessarily specific to just one program. So we're happy to work with you to show kind of from an organizational perspective what these cuts and the impacts of those cuts mean kind of on a staffing level and on an organizational level. But if it's okay, I'd love to follow up with you directly so we prepare the right visual.
Okay.
Mr. Co-Chair,
Oh, yep. Mr. Vice Chair.
just to follow up on that, I think that's a good idea. Actually, when I was reading the write-up for the Department of Health, it said there was an organizational chart in there, and I flipped the page and there's no organizational chart in the budget write-up. So I do think it would be good to have that.
Mr. Chairman and Senator Hicks, apologize for that oversight. I thought it was in there, but if it's not, we're more than happy to provide it.
It may be, but I couldn't find it flipping around in these books. So, but I did look for it.
Well, it's Mr. Chairman, Senator Hicks, it's 240 pages of light weekend reading, so I totally understand if that's the case. Mr. Chairman, moving on, if you'll look at page 75, priority number 14, this is what, again, Representative Larson had mentioned earlier, and I believe Senator Kinski asked about, with kind of the step 2 and step 3 cuts, some of them going together in concept. This priority 14 would be enforcing a consistent funding methodology for our current DD waiver, developmental disability waiver clients. By way of background, in 2013 and 2014, the legislature passed a Medicaid reform bill. I believe it was Senate File 60. And part of that, as Representative Larson had mentioned, was quite a few different redesigned components to the Medicaid waivers. One of them was a new budget development methodology for the clients, which has since obviously been implemented. But part of that reform package was to grandfather any waiver clients who had budgets prior to that time period, and this would essentially equalize the funding methodology even for the waiver clients who were grandfathered after Medicaid reform. So what you'll see here is we anticipate a little bit over 1,000 clients that would see a reduction in their individual budget amount, but also about 819 clients that would see an increase. And through equalizing the budget methodologies, we anticipate gaining about $3.6 million in general fund savings. So again, in the spirit of not candy coating things, while this was, I believe, a creative and efficient proposal for a budget cut, you do see a budget reduction for just north of 1,000 clients, and that is will be felt as a material impact to those individuals. So that's the brutish reality of a cut like this. But we'll get into those details again when we get into some of the cuts that were made to healthcare financing and the waiver units when we do the page turn.
Mr. Chairman.
Go ahead.
So, Stefan, when we look at these budgeted amounts, on the average, what percentage of the individual's IBA is used each year? Do the majority of them use 100% of the budget, or are we carrying over 15% or 20%? And in a budget like this would be a huge amount. Can you give us a feel for that?
Mr. Chairman, that's one I will easily punt over to Jesse Springer. I know we have that information. I just don't have it in front of me. So Jesse, if you can answer, please do. Otherwise, we're more than happy to follow up.
Chairman Nicholas, Representative Larson, the budget's actually already based on utilization. So the IBAs would be $20 or $30 million more than our budget. So we already factor in the utilization. So example, the comp waiver utilization is between 85 and 90% in most years. The support waiver is actually a bit lower. Utilization originally was about 50%, and it's, I think, covered more in the 75% range. We can get you exact numbers, but the actual budget we use and the federal budget requests we make are actually incorporate that utilization. Otherwise we would constantly be returning $40-50 million a year that we wouldn't be using, because those IBAs are significantly higher. And most people do not use their entire budget, but there are people that do use their entire budget every year.
Thank you, Mr. Chairman. I don't know that I got all of that. So And I apologize. So what I heard you say is we base it on utilization rates, which would imply to me that we use it all, but then I heard you at the end say, well, we don't use it all.
Chairman Nicholas, Representative Larson, the budget in total incorporates the utilization factor in total. We don't look at each individual and see, so each individual is allotted, $100. That person may actually use $80. In average, that 80% is what we budget on. So we actually budget based on the average utilization because it's quite stable over thousands of people.
Okay.
When you hit like 83 or 85% utilization, it's not stable per person, but over thousands of people, it's very stable.
And so then with this reduction, if you're seeing 1,000 individuals that would reduce it, then what you're telling me is so were those individuals whose budgets will be reduced utilizing more than they should? Or help me understand then, if we're basing it on a utilization rate, I'm trying to make that connection, because were they getting more than they deserved or what?
Chairman Nicholas, Representative Larson, they're getting more than they were assessed. So everyone is done, has an independent assessment done, and there's a formula that says it's a 1 through 6 scale, and it says, based on the points you get, your level of care requires $100,000 of care. Some people currently are getting $130,000 of care, even though their assessed need is $100,000. Some people have the same exact level of care and they're getting $75,000 of care. But they all have exactly the same level of care.
Mr. Chairman and Jesse, so they're actually getting the services, they're just getting more than, as you said, more than they were assessed for.
Chairman Nicholas, Representative Larson, they're getting more than this independent assessment says they need. I'm sure they do need it. I think that's not, I'm not debating what people are using and saying they're being wasteful. And that's not the type of cuts we're talking about here. This is just saying, some people are getting more than the assessment and some people are getting less, even though they have the same score.
Okay, thank you.
Okay, further questions? Proceed.
Thank you, Mr. Chairman. The next one, priority 15 on page 75. This is one that I have highlighted. I know LSO was following up with one or more of you on a bit of a change that's happened in the months since this budget reduction was developed. Going back to our step 2 reductions, we had a good discussion about the elimination of the Wyoming Home Services program, the state general fund program in the aging division, that in step 2, we were implementing the entire program elimination effective July 1st of next year. When these cuts were developed for step 3 last summer, we proposed a non-phased in cut to this program. So essentially make the cut immediately for the remainder of that $5.4 million budget. So $2.7 million in each cut. Given that we're nearly 6 months into the biennium and we don't anticipate this proposed cut being approved, prior to the July 1st date of next year, this is problematic now in that we cannot realize this $2.7 million of cuts, but the program is intended to be eliminated. So in the standard budget in 23-24, the full $5.4 million would be reduced. But for the current 21-22 biennium, we would have a deficit. Per the governor's recommendation of taking 50% of this and making it start on July 1st of next year, we would, if you cut that 2.7 million in half, we would still have an operational deficit of about $1.3 million. So the policy question for this committee, and this is really my mea culpa on having this cut in here, is do we cut that somewhere else? Is that just an exemption that you would graciously grant the department, or should we come back in our callbacks with options for how to achieve that cut for 21-22. Again, for 23-24, the full program amount, if this cut were approved, if step 2 were allowed to move forward, we will realize the full program savings. But given the timing now, this cut becomes problematic. So I wanted to bring it up, Mr. Chairman. I know it's an oversight on our part. But again, the timing of these cuts was kind of up in the air for a number of months. So happy to answer any questions or take direction from the committee.
Okay. Any questions? Go ahead, Stefan.
Okay. Thank you, Mr. Vice Chairman. Moving on to page 76, and we're just about done here. These, as I mentioned before, as you get lower in these priorities, the cuts become much harder pills to swallow. This is the elimination of what we call the state SSI, or state supplemental security income benefit. This is a general fund only program that's authorized in statute, and essentially for the folks who qualify based on SSI determination. There's about 3,500 individuals that receive between $20 and $30 a month in checks from this. Very similar to how the federal Social Security and SSI payments work. So this cut, again, number 17 on your list, would result in approximately $2.2 million of general fund savings, but we have it low on the priority list just because of the nature of the clientele and residents that this serves, with kind of a direct cash benefit. So happy to answer any questions there. We can tackle that when we get to the budget unit.
Proceed.
Page 77, Mr. Chairman, priorities 18 and 19, a bit of a lost in translation issue on the description here. Priority 18 is the elimination of the adult vision benefit in Medicaid. So you'll see that when we get to unit 470 in the page turn. This is, again, for adults 21 to 64 years old, vision services, which are optional per federal guidelines in Medicaid, would be eliminated here. Similarly, the next item, what you see at $650,000 of general fund savings, that would be the elimination of the adult dental program. So again, adults age 21 to 64 in Medicaid, we would eliminate that service for that population and achieve about $650,000 of general fund savings. And again, the description here was just, I think, ported over wrong. So you'll see that in unit 470 in your budget book. Again, you don't see a lot of dollars here. The utilization is quite low among our adult population because our adult population in Medicaid is quite low. We are not an expansion state, so this would not impact services for children or the elderly who are on the waiver, for example, if they're on the waiver, but still low in our priority list because, again, we're the last ones who want to eliminate benefits like this for Medicaid members. But like I said, they are optional under federal law, under federal rules, and so they're proposed here in step 3.
Stefan, how many of these would be part of your DD or ID population, your waiver population?
Mr. Vice Chair, I'm sorry, I missed that.
How many of these would be part of the comprehensive or support waiver population, or do they get those services in that waiver?
Mr. Chairman, I'm not sure on that. If Terry or Jesse could answer, please do, but otherwise we're more than happy to follow up.
Chairman Nicholas, Representative Larson, this would affect all the individuals on the comprehensive and support waiver that are in that age band. It would also, any individual SSI, employed individuals with disabilities, really any disabled program that's in the age band would also. So the federal regulations only allow us to make these type of cuts based on age as a factor, so we're not able to leave out certain populations. So it really hits every individual, like in those programs that you're thinking of.
And Jesse, is it Mr. Chairman, is it fair to say, Jesse, that eliminating a benefit like this, the services, whether vision or dental, that would be required on an emergency basis would still be covered, but that could also, I think literature indicates, we could also see to the question that was raised before, additional services at a higher level of care.
Chairman Nicholas, Stefan, that would be correct. So these are generally preventative services. So when you eliminate these, you have some percentage that can spill out into, someone doesn't get a tooth problem fixed, that spills out later, usually as an extraction of that tooth. If they don't get a vision, they might not have glasses, I see a lot of people with glasses. If you don't get glasses, it can impact your life in lots of different ways.
Representative Schwartz, did you have a question?
Yeah, thank you, Mr. Vice Chair. I remember about 4 years ago, we did a reduction to dental in some capacity. How does that correspond to what this does? And I don't remember exactly what that did back then. It's too long ago because I'm old and I can't remember.
Chairman Nicholas, Representative Schwartz, there was a more limited package done for adults. So it limited how many times a year they could get services. It for dental, removed certain services like crowns and more expensive services, but it wasn't a full benefit elimination. So that it saved a lot of money in the previous round, but it didn't fully eliminate the dental. This really takes any service you would get in a dentist's office off the table. And then similar with the vision, it would take optometrist. I'm blanking on the other, but that you're actually receiving in an office.
So essentially what I didn't like before is worse now. You don't have to answer that.
Thanks.
It's an opinion. Stefan, proceed.
Thank you, Mr. Vice Chairman. Moving on to also on page 77, priority number 20. This would be freezing the developmental disability wait list for the biennium. And we'll get into the description when we get into that unit. But freezing that wait list would essentially result in about $1.7 million of biennial savings. And then finally, Mr. Vice Chairman, priority number 21 on page 78. This is an additional 2.5% provider reimbursement rate reduction for the provider types that we mentioned before. Only a few would be excluded. This would kind of go across the board. And Mr. Chairman, this is if step 2 and step 3 were taken, this would represent a 5% across the board reimbursement rate reduction. I did want to point out to the committee that relatively speaking, and I know many providers would balk at this description, but relatively speaking, Wyoming Medicaid has historically paid higher rates than our surrounding states, and that has really been an important strategy in guaranteeing or providing good access to our Medicaid members across the state. Higher rates equal more providers taking Medicaid clients, and we actually see around 99% of physicians who accept Medicaid clients, which is really, really good for a state where, in other states, New Jersey, for example, it's below 50%. I mean, it's much different story in some other states. So what you'll notice when the department was asked to cut, about 14% of its general fund budget, and across step 2 and step 3, you see a 5% reimbursement rate reduction in Medicaid. That's an overt strategy because we know that a lot of budget cuts historically come on the backs of providers, generally speaking, and a lot of these cuts, certainly do that. But the reason you see a lower percentage of across-the-board rate reductions is for that reason, to try to maintain as much access as we can for our Medicaid members. And then finally, Mr. Chairman, priority number 22 in step 3, this is what I mentioned before when we were discussing the developmental preschool cuts, that you would see an adjustment for that cut. And Director Hibbard had mentioned, using savings, school foundation savings over in ETS as kind of a temporary backfill to part of that cut. So I won't get in the middle of that fund discussion. Let Director Hibbard address that, or we can wait until we get to that particular budget unit. But Mr. Chairman, we are more than happy to take questions on step 3 or dive right into our page turn of the budget, which I'm confident we can get done in less than an hour.
Okay. Somebody start a pool on this. Let's see how close to an hour we get here. Okay.
Mr. Chairman, members of the committee, my name is Eric McVicker. I'm the Chief Financial Officer for the Department of Health. I'm going to guide you through the book similar to what we've done in past years, where I'll tell you the unit, and then I'll tell you whether that unit has a supplemental request, whether it has a step 2 reduction or a step 3 reduction, and then I'll turn it back to Stefan to elaborate more on those items. So
as you do it, give us paid numbers as well.
yes, I will. Starting on page 79, we start with our first division, which is the director's office. That page 79 is just a summary page. So if you flip to page 80, that is our first actual unit. It's unit 101, and it's called director's office. And in this unit, we did have some step 2 reductions.
Mr. Chairman, our step 2 reduction in this unit that you see here is the elimination of 2 positions, one full-time and one part-time. One of them is in our policy unit, which you've come to know, the director's unit for policy research and evaluation. We're eliminating an analyst staff there, a staff member. We did eliminate another analyst staff in that unit to help fund and provide the state hospital staffing earlier this year. But these are just 2 position eliminations, but happy to answer any questions.
Mr. Chairman.
Representative Summers.
Mr. Chairman, thank you. If you go to your summary table on page 81, you took no reductions in your 200 series in your admin, and no reductions in your 900 series. If those, and I don't know what those 900 series are for, but particularly in the 292 on the maintenance contracts, we've seen other agencies really try to find a way to redo contracts, find savings there. You've got 525,000, and did you even look at that to try to renegotiate?
Mr. Chairman, Representative Summers, we did. The short answer to the question is that the director's office does shoulder a lot of the administrative and support service burden for the entire department. So all of our operating divisions, there's many services in our 200 and 900 series that we just fund out of the director's office for more services, I'll say, than just the director's office here. But Eric, if you have anything to add to that, please do. Representative Summers, we're happy to take a look at that, but in reviewing those expenditures, we didn't find anything to squeeze.
Yes, Stefan, Mr. Chairman, and Representative Summers, things like Kronos, our timekeeping system, and things like that apply to all of the operating divisions. We pay for a lot of that out of director office costs, so that is true. So next page is page 83. It's unit 130, and it's our vital statistics area. And there is a step 2 reduction in that unit.
Mr. Chairman, this is another position elimination of an AWAC employee.
Any questions?
Mr. Chairman.
Go ahead.
Mr. Chairman, I'll only elaborate on this on a couple of them, but if you go to 85 on your summary page, once again, your 200 series you didn't touch. And I think of all the people you did touch, but you didn't touch your 200 series in two units. And this includes out-of-state travel of $11,000. What do you need to do out-of-state travel for in this unit?
Mr. Chairman, Representative Summers, to a couple of those points, you'll notice on page 85 that this is a heavily federally funded unit, and the Vital Statistics Office, most of these contracted costs are for systems where we provide death certificates, birth certificates, marriage certificates, divorce certificates. So any cuts here would again impede service to the residents. So that's again some of the reason that you don't see a lot of 200 series expenditure reductions here. In terms of out-of-state travel, Mr. Chairman and Representative Summers, I will follow up with the administrator there. We do not have any planned out-of-state travel this year for really any of our divisions or units unless it's absolutely, crucial or federally required. So I think that could be something that comes out.
Okay, Mr. Chairman, that concludes the director's office. If you look at page 87, that starts our healthcare financing unit. And page 87 is like on the, we saw before, it's just a summary of all the different units. So if you flip to page 89, that's our first unit in HCF, and that's HCF admin, unit 401, and there is step 2 reductions there.
Mr. Chairman, these a lot of our healthcare financing units here, just to prepare the committee, we didn't think or find a better way to do this in the budget book. So you'll see a lot of our cuts in these units. If you flip on the page for this one, page 90, you can see a breakdown in the table of all of the administrative costs to unit 401 that we are essentially cutting. So we're happy to go through them in detail or just stand for questions. But again, a lot of these administrative cuts will bridge quite a few different areas.
Mr. Chairman.
Go ahead.
Mr. Chairman, thank you. If you go to your summary table 92, you cut, basically half of your out-of-state travel, but you still retain a pretty large out-of-state travel budget for this unit. And I'm just, and in in-state travel, but I can understand in-state, maybe not this year. So kind of curious why you didn't shave some there. But talk about your travel in this budget.
Mr. Chairman, Representative Summers, in terms of the in-state, you're right that we've been prevented from doing a lot of in-state travel this year. As you know, our department, we will revert funds that are unspent, and so I think that's certainly planned here. In terms of out-of-state travel with our healthcare financing and our Medicaid program, there are certain types of, for lack of a better term, continuing education and certifications that have to be had that aren't offered in state. And I believe a lot of those expenditures for out-of-state travel in a year that's not like this with COVID-19 would be in that area. But happy to get a breakdown of what that looks like in a normal biennium.
Yeah, and my guess is that even those out-of-state travels are now being done virtual.
And Mr. Chairman, probably will be into the future, because that's actually a place every state agency across the country can save money now. So yeah, I'm curious, because I'm not sure have you expended any money there? You know, and do you plan on expending any money this next year? So thanks.
Mr. Chairman, Representative Summers, it's a good point and a fair point, and we'll do an analysis over the first 6 months of the biennium to look at that. But again, I think it's worth looking into. What we were trying to avoid was, given that this is not a normal biennium, in subsequent years when we do have to start sending folks for required conference or certifications, to not have to come back to this committee asking for that money. But happy to take a look, sir.
Yeah, and we welcome one-time exceptions too. Evan, go ahead.
Mr. Chairman, this morning we provided you the report that shows you funding by object class. A great example on page 85, Representative Summers brought up that $11,000. In this case, you can go to that funding report by object class and now know that that is federally funded, that $11,000. So they wouldn't get us, what it actually do is if you cut $11,000 with general funds, then you're cutting general funds that don't exist because they're using federal funds. But a good example of leveraging that report.
Yeah, okay, we'll try to cross-check that before we start slashing and burning. Representative Stiff.
Mr. Chairman, Mr. Johansson, again, kind of made perhaps old ground, but page 92 on personnel, you have $20 million of payroll and then no step 2 or step 3 cuts. I can't tell what's general fund, what's maybe other federal funds. But if we had $20 million in another agency for payroll and there were no step 2 or step 3 cuts, we'd ask why.
Mr. Chairman, Representative Stiff, absolutely fair question. I will mention that all of our salaries in healthcare financing are included in this unit. So you won't see them across the other units. So it does look very top heavy. Typically, our federal match is 50-50. but with many staff who work on technology projects or other things that have been authorized by the federal government, you'll have a 75% federal match and sometimes a 90% federal match. So we're more than happy to provide the breakdown of what the staffing looks like in terms of not only the dollars, but the number of people. But like I mentioned before, in our entire Medicaid program and healthcare financing division, again, it's a little bit north of $1.4 billion biennially between state and federal and other funds, and just north of 100 staff. So relatively lean when you think of a healthcare insurance operation, but we're more than happy, Representative, to provide that breakdown on actual spending.
Mr. Chairman,
Thank you, Mr. Chairman. Stefan, on that same page 92, could you remind me what code 204 is, communication?
Mr. Chairman, Representative Kenner, I'll defer to our CFO on that.
Yeah, Mr. Chairman, Representative Kenner, that would be phone costs, any kind of contracts, things we have for the different communications that we have in Medicaid would be all in that unit or that object code.
So the question is why it's a $500 million amount. So that's where's the bulk of that go?
Chairman Nicholas, Representative Kenner, that's a majority of that is printing in newspapers for legal printings we have to do for estate recovery. And then the other bulk of it would be paper printing to send to clients or to providers. So it's not that's not used for the 100 people to communicate with each other. That might be $1,000 of that. It's for mass printings to send to the 80,000 people or to the 30,000 providers, and just most of it's postage in that sense. So we spend about $200,000 a year on mailing and postage. And then the rest of that would be legal publications. And we are working on reducing those amounts. And I think we did note some of those.
Representative Summers?
Yeah, Mr. Chairman, thank you. Kevin, can you resend me that? Because I can't find your name on a email this morning.
Mr. Chairman, more than happy to. That was delivered to LSO by Mr. Mike Ogle. So we'll make absolutely certain that you have it.
Don?
Mr. Chairman, it was part of the noon or 11 a.m. email from me. I think it was the second and third link in number 2.
Okay, great.
Okay, Mr. Chairman, moving on to page 94. That's unit 420, and it's the Children's Health Insurance Program, or CHIP program. And there is a step 2 reduction in that unit.
Mr. Chairman, this is what we mentioned before with the CHIP program administration coming in-house and transitioning to a fee-for-service model with us, the Department of Health, administering it as opposed to paying basically a capitated methodology to a private contractor, which was always Blue Cross Blue Shield in previous years. So this is the step 2 reduction that we realized some administrative savings by administering this program in-house. And this was part of a legislative direction from previous biennia and also in the legislative session this past year.
Questions?
Okay, Mr. Chairman, the next unit is on page 96, unit 460, adult services. There's some step 2 reductions as well as step 3 reductions in this unit.
Mr. Chairman, going through briefly the step 2 reductions, which we've already covered. The first one that you see on page 96 is, again, a new 2.5% reduction to expenditures across the allowable provider types that we mentioned. And then also, if you look at priority number 26 on page 97, you'll see some of the alternative reductions that we mentioned before with capturing federal match that has increased as a result of the COVID-19 public health emergency.
Representative Schwartz.
Thank you, Mr. Chair. I'm just curious, do you have any expectation of how many providers might cease to provide the services based on this reduction?
Mr. Chairman, Representative Schwartz, across all of our Medicaid reductions, it's really difficult to say what those tipping points would be. There's a lot of exogenous factors that I think go into, a provider's decision, whether it's financial or otherwise, not to accept Medicaid clients. I think, again, going back to my previous comments on the 2.5% in step 2 and 2.5% in step 3, the reason we tried to keep that relatively low to the 14% that the department was directed to cut was for that very reason, so that we don't tip that scale if we can avoid it for access for the Medicaid members. In addition, another reason to keep those reimbursement rates low, not only to keep our providers in business and keep them compensated for the work they do for our clients, but also the more that when you start to get into severe budget cut territory, the federal government can come in looking at and review basically your access for your Medicaid members to see if it's sufficient, or if they would essentially take action against the state for unnecessarily limiting access by nature of a budget cut. So it's really hard to say, Representative Schwartz, of exactly, if we cut this much, we'll lose 100 providers. We've tried that, and I can't find a good methodology to project that for you.
Follow up, if I may.
Please.
Thank you. So I guess part of what I was wondering is if you're receiving any feedback from providers yet.
Mr. Chairman, Representative Schwartz, it's all very positive. No, that's a bad joke. Obviously some concern among all of the provider types that are going to see leaner times as a result of these cuts. We have worked very well with our healthcare associations, our providers, on communicating with them both in step 2 and step 3 what's coming and how we can work to ease the burden, so to speak. I'll reiterate, Representative Schwartz, what I mentioned before, that through our upper payment limit and what we call our IGT and our GAP payment programs, we are going to work, and healthcare financing has already started working this year to leverage as much of that as we can to essentially attempt to make our providers as whole as possible by drawing down as much federal match as we can and redistributing it to those provider types that are particularly impacted by these cuts. So there are some ways to mitigate the pain, and we're working through some of those.
I'm sorry, I don't know IGT.
Intergovernmental transfer.
Okay, proceed.
Mr. Chairman, the step 3 budget reductions in this unit begin on page 98. You'll see the elimination of the state SSI program payment that we mentioned before, as well as priority 21 on page 99, which is, again, you'll see this in many units, the 2.5% reduction across most provider types. That will be kind of a recurring theme, both in step 2 and step 3 in many of these units. And that concludes unit 460.
Representative Larson.
Yeah, thank you, Mr. Chairman. And Stephan, if I could go back to page 97 on that clawback explanation, and we have a similar one-time savings due to the enhanced FMAP thing. And I don't know if this is a question to you or to Kevin, but so we've got what I will call an artificial enhancement of our FMAP due to COVID. And so we're paying less general funds dollars for Medicaid reimbursement because the feds are giving us more. That's going to go away. And then we're going to be right back to where we have been traditionally. And so I'm kind of wondering why we're doing that as ongoing rather than one time. It would seem to me that it would be at least easier for everybody involved to say this is a one-time cut we get, and if it carries over the next biennium, we could give back a reduction again. But if we carry it forward as a biennial cut and they come back to the 50-50 match that we have had historically, then you are going to have to make a request because nothing has changed in Medicaid. It's just the reimbursement has changed. So you're going to have to come back in this and then, in the Part D, the Medicaid clawback, and you're going to look for 18.4 million in some of this stuff. And so I'm just trying to, you're going to come back and we're going to start drooling and gnashing of teeth and wondering why on earth we have to give you this increase of funds when it's all been a paper shuffle. And so I'm trying to understand why we would elect to biennialize that instead of one time.
Mr. Chairman, Representative Larson, so I'll certainly defer to Kevin from the budget's perspective. Him and I did arm wrestle over this a little bit, and he's a much stronger guy than I am. But it's really 6 of one, half dozen of the other. So the way you characterized it is, I think, accurate. That right now we have some one-time savings through a temporary increase in federal match that we know is going away at some point. That capture here being biennialized, you're right. If all things stayed the same, we would likely have to come in the next budget and request funding. Now, there's a lot of factors that could change that. So that's one side of the coin, one option. The other option, to your point, Representative Larson, is if this was just a one-time cut and we take it for 21-22, equally in the next budget session, we might be having to cut the department harder because we bridged a gap essentially in 21-22 by capturing some savings by leveraging the federal match, and we might have to again, if the revenue situation in the state didn't change and we were still needing to take that level of funding out of our standard budget, we'd be in a cut situation. So it's on one option, what's in the book here, we might be coming back in the next budget for an exception request. The other option is if you make it one time, we might be working with you all to cut further in 23-24, if that makes sense. And not meaning to put words in Director Hibbard's mouth. So if I did, Kevin, please correct me. If you're listening.
Mr. Chairman, I think that's a good summary. Just basically what's taking place with FMAP now. We do not know how long it's going to be. The law says the additional funds are available for states from January 1st, 2020 through the quarter in which the public health emergency period ends, provided the states meet certain conditions. So right now we're in the second quarter, the first quarter, or the first portion being January through June. We've enjoyed this from June until through December. If it crosses in one day into January, then we get a full quarter, and then after that, until the health emergency ends, then the Department of Health will be able to leverage a smaller match, 6.2% on FMAP, and hopefully be able to extend or mitigate impacts further with one-time money. But the other thing about this is that when we're trying to achieve a budget for 23-24 or a reduction target as significant as the $85 million the Department of Health has to cut, we have to consider all the options. And that's my way of explaining it in a different set of words than what Stephen shared.
Thank you, Mr. Chairman.
Proceed.
Eric, you're muted.
My apologies. Mr. Chairman, we're on page 102, the next unit, unit 461, Children's Services. There is a step 2 reduction in that unit.
Mr. Chairman, this step 2 reduction, priority 17 on page 102, this is essentially we will mandate a 90-day supply of prescription drugs. And what this does is essentially eliminate 2 restocking or refilling fees. So a lot of insurance programs and plans have gone this direction. So this, we anticipate a $500,000 reduction in general funds in step 2. Also, Mr. Chairman, there is priority number 19. We've talked about this at length earlier today. We would establish the prior authorization threshold for adolescent behavioral health services at 30 visits. Beyond 30 visits, that would require prior authorization and a healthcare provider demonstrating medical necessity for those services.
Mr. Chairman, not seeing any questions. Next unit is on page 105. It's unit 462, out-of-home placements for children. There's step 2 and step 3 reductions here.
Mr. Chairman, the step 2 reduction on page 105 is what we discussed prior. This is basically a coding change to pay on a per session basis instead of paying on 15-minute units. And we anticipate a 1.5 million in general fund reductions. If you flip to page 106, our step 3 reductions, as we talked about before, would be eliminating the children's mental health waiver and the care management entity that goes along with it. You can see in total on page 107 that general fund biennial reduction would be approximately $2.9 million.
Questions? Proceed.
Mr. Chairman, next unit is on page 110, unit 463, nursing facility services. There is a step 2 reduction in this unit.
Mr. Chairman, this step 2 reduction is what we were just discussing, that by leveraging the match increase, we can have some modifications to the upper payment limit programs due to the COVID-19 emergency. And we think that's approximately $4.5 million of reduced general fund by leveraging the federal funds.
Stefan, does this require a footnote modification by us?
Mr. Chairman, I don't believe it would. This would just be us. As long as the public health emergency is in effect, we can leverage this funding. So let me follow up on that. I don't believe we need a footnote modification, but I'll double check and get back to you.
Well, if the emergency goes away, then what happens? So would it make more sense to do it even if it's to prepare for that?
Sure, Mr. Chairman, I'll follow up on that. I believe initially my answer is no. A lot of this was capturing the funds that were available in the last 5 months or so of the 1920 biennium when the match was put into place.
Proceed.
I think, Stefan, on page 110, we have PACE in here as well. This is step 2.
I think I subconsciously skipped over that, Mr. Chairman. On page 110, we do have the elimination of the PACE program. We discussed that before. This is calculated with the required phase out of the program in there, but this is in process currently, and we're working to transition those clients to other services. And we've been doing that for the past several months. So this is, again, sorry for skipping over that, but this generates approximately $1.7 million of general fund savings.
So how far are you in the phase out? This just suggests that, well, what if the legislature doesn't like it? How do you phase back?
Mr. Chairman, that's a good question. I think we're in the 6-month phase out period. Jesse can correct me if I'm wrong. I believe we're a couple of months in. Essentially, we would be kind of rebuilding the program and transitioning the clients back if this cut were to be rescinded.
Chairman Nicholas, I believe the final date is March 30th, 2021, and that the program would end at that point. And and most of the individuals on the program would have already been and would have already been transitioned well before then. So we're transitioning 30 or 40 people a month. So, by the time the session meets, there will not be many people in this program.
Okay. Representative Schwartz.
Thank you, Mr. Chairman. I was unaware of this program. I don't recall when it started. Was this established as a pilot program or something that it's only in Cheyenne? And so I'm getting affirmation that that's a yes, but it was never offered to, there was never any attempt to expand it.
Mr. Chairman, Representative Schwartz, I'll sound like a caged bureaucrat here. This was authorized as a pilot program, but I don't believe it ever received an appropriation. And so the part of the lack of expansion, a couple of things. One was probably financial. Secondly, this concept of a program, which I think 20 states or so have some version of PACE operating in a few cities or a few areas. This really came, before a lot of states really heavily invested in their home and community-based long-term care waivers, which we obviously have been doing as a state. So the concept, again, a lot of efforts come, to try to keep people and get people out of nursing homes, and this was one of them. And a very popular program, don't get me wrong, but yeah, it was offered kind of geographically only here in Cheyenne and not expanded over the years.
Thank you, and I'm sorry I make you feel like a caged bureaucrat.
Mr. Chairman, the next unit is on page 113. It's unit 470, optional adult services. and there's a step 3 reduction here.
Mr. Chairman, in Unit 470 on page 113, you can see the step 3 reductions that we just discussed of eliminating vision coverage for adults and dental coverage for Medicaid adults as well.
Chairman Nicholas, earlier we mentioned this was limited to ages 21 to 64. We've been researching behind the scenes that we believe this is all individuals 21 and up. But we will provide clarification after the meeting.
Okay, thank you.
Thank you.
Mr. Chairman, the next unit is on page 116. It's 472. This is the Wyoming Life Resource Center part of Medicaid, and there is a step 2 reduction.
Mr. Chairman, this step 2 reduction is the elimination of chiropractic services, and I have to be honest, maybe Eric or Jesse can clarify. I'm not sure why this cut is reflected in the WLRC unit, but this is what we discussed before with some of the questions early on in our testimony from, I believe, Representative Simpson, that this would be the elimination of that chiropractic benefit that was added a couple of years ago.
Do you need any action on the part of us for this, Stefan?
Mr. Chairman, I don't believe so. I think all of these were reviewing statutes since they are authorized, but I think the subject to available appropriations language is peppered throughout, numerous Department of Health and certainly Medicaid statutes. But we'll follow up if we think we need legislative action.
Okay, proceed.
Next unit is on page 118, 483, long-term care waiver service, and there's step 2 reductions here.
Mr. Chairman, this is the elimination of the Project Out program that we discussed before, which again, in the services that are offered through the waiver and other efforts of healthcare financing to invest in home-based and community services, this was a general fund reduction of approximately $400,000 for this program.
Questions? Proceed. Oh, wait, Representative Stiff.
Chairman, Mr. Johansson, just to clarify, so with the focus on home health services, does the funding basically stay intact for home health care agencies, except that they might get a total of a 5% reduction in their fees? Or am I misunderstanding the big picture?
Mr. Chairman, Representative Stith, I think you are understanding the big picture. Jesse, feel free to correct me if I'm wrong there.
Chairman Nicholas, Representative Stith, I think for home health specifically, I think that would be a correct understanding, unless that home health agency was providing waiver services, possibly, where there are some different changes to waiver. But if you're providing home health and you're a licensed home health agency, that's what I understand.
Okay, Mr. Chairman, next unit is on page 120, 485, comprehensive waiver. This unit has all 3. So we've got an exception request, a step 3 reduction, and a step 2 reduction.
Mr. Chairman, I would direct the committee's attention for this step 2 reduction to page 121. You'll see the table on page 121 that gives all of the step 2 reductions to unit 485, which is the comprehensive waiver. It includes the reduction in the homemaker service, the state plan, what we're calling state plan duplication, the wait list changes, reductions to some specialized equipment, and the 2.5% provider rate reduction. Total here for step 2 would be approximately $6.5 million general fund.
Mr. Chairman.
Go ahead.
Mr. Chairman, thank you. Stefan, I just have a question, kind of a bigger picture question. Have you engaged every unit that had a general fund appropriation in this cut budget? In other words, we're only seeing the units that you have cuts in. I would assume that you engaged every general fund unit, but I'm asking that.
Mr. Chairman, Representative Summers, absolutely. We combed through every unit here. We had multiple options developed that we discussed with the governor for various ways to compile these packages. So yes, every single unit with $1 of general fund appropriations was considered.
Mr. Chairman, that's not my question. My question is, did you cut $1 out of every general funded unit that you had?
Mr. Chairman, Representative Summers, no, it was not across the board that way.
And so, Mr. Chairman, my follow-up question is, and you can get that for me, is how many units does that entail? And how many general fund dollars are in those units that you did not engage in this process?
Mr. Chairman, Representative Summers, we'll prepare that for you for both step 2 and step 3.
Thank you.
Mr. Chairman.
Representative Larson.
Thank you, Stefan. Can you just help me then? Like I'm looking at the homemaker component of that, and if you've got somebody on the waiver and they're in a community program, part of that waiver then would cover the homemaking and allow them to leave in the least restrictive manner, but may not have the homemaking skills that would be reimbursed back to the community provider. First off, am I seeing this correctly? And then any suggestions on how, is that just something that would have to be made up in some other manner? Jesse?
Mr. Chairman, Representative Larson, you're right, and I'll have Jesse elaborate on that. This is kind of an unfortunate reality of a service that goes away under the waiver.
Chairman Nicholas, Representative Larson, I think that these individuals wouldn't have someone to clean their house, possibly do light chores. That's what the homemaker service is offering. They would still have other supportive services, and then most likely a lot of unpaid supports that family members are providing. I think, we don't know how much unpaid supports are being provided to disabled and elderly individuals, but it, I think, far exceeds what the state is paying for.
Mr. Chairman, follow up, and fair enough, Jesse, but have you guys contemplated those situations where there may not be a family member? Hygiene's a big deal, and now we are, just the general condition of a home, and to allow somebody to live with a, in a more free atmosphere. In those situations, what do we do?
Chairman Nicholas, Representative Larson, I think that'll come up on the second reduction on this list, the rehabilitative services, where I am aware that the department's already receiving a lot of client feedback and pushback on that reduction, less so on the homemaker, but there are light cleaning and type services that can be provided under the other personal care. So while you're getting 8 hours a day of personal care, that can include, tidying and helping that person with hygiene, or home health in some cases does include that. This is a standalone cleaning service. So, you might be getting, some individuals are getting a lot of services. And so, and the person's not necessarily hands-on on that with that person the entire 100% of the time. So there could be some cleaning services or other things happening at that time. But yeah, I think if those situations arise, the department likely would have to look at the living situation and what's making it unsafe.
Well, and thank you, Mr. Chairman, and follow up if I may. And I appreciate the challenge that you guys have. And I'm just, I'm kind of just standing on your shoulder here a little bit, Jesse, and saying, yeah, what if? Because I think that there are exceptions to these, and I'm hearing you guys say, well, we'll work on it. And I just, again, with all of the admiration in the world for you guys, but I hope that we're working on a plan, that we have a policy in place that when those are identified, that we don't have to react to each individual one. And so I'm sorry, I shouldn't be. Would you?
Representative Nicholas, Chairman Nicholas, Representative Larson, the other services, including the residential services, which are provided to the most severe clients. So a lot of those are in residential rehabilitation. Those do include light cleaning in that payment. So I think I would, and the personal care services do include light cleaning in the service definition. So the individual should be receiving, if someone's getting $100,000 of care and they're a high needs individual, they should be getting light cleaning of their home in that bucket without homemaker. This would be an additional layer of cleaning and in addition to that. But if it's becoming unsafe, I think that, you'd have to look at the residential placement and the personal care. And that's a lot of what the case managers do, is to say, are they getting good care from their primary care, their primary layer of care? And it could be more of a service issue there that would have to be addressed. So I think there are going to be scenarios from these cuts that do actually increase the workload of the state team that's working on this, because they're going to have a lot more cases to follow up on in terms of safety, in terms of, all sorts of things. And so it's not necessarily that eliminating this, at this time, eliminating these things is not reducing our workload. People are much happier when you give them more money. So when you give them less money, they're less happy, and there's safety issues that will have to be followed up on and all sorts of things.
Thanks.
See.
Thank you, Mr. Chairman. On page 122, you'll see the step 3 reduction in unit 485. If you'll flip to page 123, again, you can see a table of the breakdown of those step 3 proposed reductions, including the heightened scrutiny and criteria for the extraordinary care committee requests that we discussed, the additional 2.5% provider rate reduction, the kind of equalization of budget development using the standard assessment tool, and the wait list freezing that we've discussed. Total reductions here proposed in step 3 is approximately $10.2 million general fund. Eric, you are muted.
Mr. Chairman, on page 124, there's also a supplemental request in this unit. That was the tobacco fund reinstatement issue that we had discussed earlier.
And with that regard, I think that we had some concerns that we're overtaxing the tobacco fund. So Kevin, would you just make available to Don your calculations and so that we can cross correlate, and also make sure that we don't have other committees tack in onto the tobacco fund, because it's a ready target.
Yes, Mr. Chairman, absolutely. We'll collaborate with LSO to see that you get it.
Okay, next unit is on page 126. It's unit 486, the support services waiver, and there is a step 2 reduction there.
Mr. Chairman, the step 2 reduction on page 126 generates approximately $118,000 in general fund. And this would cease what we call level of service assessments provided by the University of Wyoming for lack of a better term, really for research purposes into certain types of conditions. This is not required, and essentially we would stop doing this for the time being.
See?
That concludes the healthcare financing unit division will go on to the public health division. So starting on page 130 is 501, which is the public health division administration unit. And there are step 2 reductions here.
Mr. Chairman, in unit 501 on page 130, you'll see a reduction in and out of state travel, as well as some changes to the general fund and tobacco settlement fund distribution. We believe a $111,000 general fund reduction will be achieved here.
Mr. Chairman.
Oh, go ahead.
Mr. Chairman, just quickly, if I could get Kevin up so I understand his chart, and then I won't ask again. So Kevin, if I look at your handy dandy chart that you provided us, and it says out of state travel 200 series, general fund is 33,658. Does that number mean that is how much is in that budget more than was spent the last budget cycle, or what does that number represent?
Mr. Chairman, are we discussing the funding by object series?
It's got 222 in it. Travel out of state. So I don't know. I punched one of your buttons, I think by object.
Yes. So what that report will tell you is that object series, that 200 series, for example, has $33,000 of general funds, and maybe it says $33,000 of federal funds. So in that case, it's a ratio of 50-50. Or it might say all zero general funds and, like the last one, all federal funds. So it's 100% federal funds.
So that number is how much has been budgeted, or period? Not,
Mr. Chairman, that is how much of the budget is either general funds or federal funds.
gotcha. All right, thank you.
You're welcome.
Okay, next unit is on page 135, unit 503, emergency medical services and hospital preparedness. And there's some step 2 reductions and a step 3 in this unit.
Mr. Chairman, the step 2 reduction to unit 503 is on page 135. Essentially reduction in office administration, travel, and training expenses. So in the category of administrative costs that we were discussing before, we think we can achieve a $103,209 general fund reduction. The step 3 reduction, Mr. Chairman, is on page 136. Again, additional cuts to office administration, travel, and training along some of the same categories for a total step 3 proposed reduction of $456,458 general fund.
Questions? Proceed.
Okay, on page 141, next unit is 510, rural and frontier health. And there is a step 2 and a step 3 reductions in this unit.
Mr. Chairman, very similar to the previous unit, unit 510 here does have a step 2 reduction to reduce office administration, travel, and also manipulate some grants and aids to leverage additional other fund sources for a total general fund reduction of $182,424. And on page 142, you can see our step 3 reductions to unit 510 would be salary reductions, 100 series reductions to the rural and frontier health unit for operations and programs for a total general fund reduction of approximately $667,000.
Okay, proceed.
The next unit is on page 146. It's immunization. And there's also a step 2 and a step 3 reduction in this unit.
Mr. Chairman, this is the YVIP, the vaccination program we discussed before. In the step 2 reduction, we would limit the availability of, or the state provision of these vaccines to private providers for a total general fund reduction of $3.5 million. And on page 147 in step 3, additional reductions to this program area of approximately $1.8 million general fund, essentially making those vaccines only available from the state to public health offices and federally qualified health centers.
Stefan, we had some questions over the last couple of biennia on the particular vaccines that you make available. And 1 or 2 of them were extremely expensive and they weren't administered around the states all around us. I can't remember what it is, but I take it you've gone back and reviewed the individual vaccines that you're making available.
Mr. Chairman, yes, that review has taken place, part of which developed these budget reductions. I'm not sure exactly the vaccines that you're referring to in the previous biennia that we've reviewed, but more than happy to look into that or invite Stephanie Pyle to comment on it now.
I can't remember, but Don, you call it, it was like $2 million for one particular vaccine.
Mr. Chairman, I recall the conversation. I don't recall the amounts.
All right. I'll see if I can find it. Go ahead.
Next unit is on page 150. It's 523, maternal and child services. There's a step 2 and a step 3 reduction here.
Mr. Chairman, in unit 523 on page 151, you'll see a step 2 reduction for in and out of state travel, approximately $10,000 general fund. And on page 152, same unit 523, you'll see step 3 reduction proposal for salary and reduction of funds for children and special health services and county grants for a total general fund reduction of $451,000.
Mr. Chairman, next unit is on page 155. It's unit 525. It's women, infants, and children, or the WIC unit. There is a step 2 reduction here.
Mr. Chairman, the step 2 reduction for the women and infant children unit will be approximately $105,000 and will come through contract reductions. This will be 900 series contract reductions.
So Stefan, I'm curious, with the step 2 reductions that you've already implemented, how are you as a department monitoring what those cuts are, monitoring complaints, monitoring impacts to providers out in the field in a way that may or at some point we can quantify overall the impact of deleting these types of services across the state? Is there any way we can do that, or have you thought about how we can actually know and have a real understanding of what these impacts are, other than getting a phone call from our constituents or from a healthcare provider?
Mr. Chairman, it's a good question and a tough answer. To your first point, yes, we're working with all of the provider types, both formally through federal requirements, as well as with our health associations and just general communications to manage and monitor the impacts. And as Jesse was stating before, specific to the waiver, to really work with clients and case managers to make the transition as easy as possible, knowing that there's going to be some material pain that we all go through with these cuts. In terms of monitoring the financial impact, that's a little bit more difficult. We do have some publicly available sources through cost reports for hospitals, for nursing homes, as well as nonprofit Form 990s to look at the overall financial health of various provider types. But it is quite difficult to tie specific changes in those financial indicators to these types of specific changes. But it's something that we look at on an aggregate basis to monitor the health of provider types as best we can.
Have you made a request to any and all entities around the state that are impacted to, if they can, to monitor those impacts and report to you or back to the agency, so you have more of a comprehensive understanding of the objective and subjective points of view of all those providers?
Mr. Chairman, we haven't made that request specifically. Obviously, in a lot of these cuts, there are numerous steps we have to follow per regulatory requirements. I think to your last point, the subjectivity of the information would be difficult to standardize in what the impacts are, unless we had some, again, standardized way, sort of cost reporting format to tie, some sort of self-declared report directly to the impacts of these budget reductions. And if there's ideas on the methodology for that, we are most certainly all ears. It's from an economics perspective, it's hard for me to think of a way to, control and adjust for all of those different exogenous variables.
It just appears to me that there ought to be a mechanism, if it's no more than just a holding of the hand kind of a concept, that you recognize and respond to the impacts that this is going to cause and it is causing, and an ability to have someone complain and just keep track of it as best as you can, because I think it's just an important idea. And then my other question, while I'm talking, so I think it would be useful, we cut $120 million in 2017 out of your budget. You came back a year later and we added back, I think, 30, 40 million because we overcut. And yet you're doing the same thing again here. So I think it would be useful for us to see how much was added back, what was cut in 2017, what was added back, and then where this leaves us, say like pre-2017, but 2016 up until when these step 2 and step 3s are fully implemented. Does that make sense?
Mr. Chairman, it does make sense, and we're happy to look back across the 2017-18 biennium that we did a cut. I will reiterate some comments I made before, where a lot of that add back that you mentioned where we came in with a budget shortfall, primarily in the healthcare financing division, was really related to two factors. One was increased enrollment and growth in some of our aging population services, which we've talked about before. And the second was the delay in which some of our budget cuts from 2017, 2018, the delay that happened before they actually took effect for a variety of reasons. And that's why in this budget, I will mention, we learned from some tough lessons in 2017, 2018 of cuts that are easy to make and cuts that really take a lot of time to implement. So we did, implement a different strategy with these, hopefully being able to realize the majority, if not all, of these cuts on a more timely basis. And also, as you saw in step 2, those utilization reductions and cost savings that we had intended in the 2017, 2018 cuts that really started to materialize towards the end of that biennium and into last biennium, we've captured those in these cuts as well.
Okay, and as we proceed, we've got 100+ pages to go, or 80. So like the short ones are a couple $1,000 in travel, things like that. I think we can ding those pretty quick.
Okay.
Will do, Mr. Chairman.
Next unit's on page 16526, public health nursing, and that one is a reduction of in and out of state travel. So I think we can move through that if you don't have any questions. Next one, page 163, unit 531, cancer screening, and there's step 2 and step 3 reductions here. Looks like those are the same. Same kind of in and out of state travel and et cetera. Next unit is on page 168, 532, public health laboratory, and there is in and out of state travel and a step 2 reduction there. Next one is on page 172, unit 534, communicable disease. There is a step 3 reduction there.
Mr. Chairman, this reduction is relatively small, approximately $200,000 general fund. It's a reduction in maintenance of effort funding that is used to purchase HIV medications and medical services as part of what's known as the Ryan White program.
Okay, proceed.
Next, page 176, unit 539, injury and chronic disease prevention. There's step 2 and step 3. In-state travel and also office supplies and operations. So kind of admin cuts there.
Proceed.
Page 180, unit 540, infectious disease epidemiology. That one also has a step 2 out-of-state travel reduction. Page 183, unit 550, substance abuse and tobacco prevention. This one does have an exception request and also a step 2 reduction.
I think we've covered this pretty well, haven't we? Got any more questions? All right.
That ends the public health division. We'll start on the behavioral health division. So page 188 is the first unit, 2501, and that is the behavioral health administration unit. There are some step 2 reductions. You can see there's a whole list of them on page 188. I think we can answer any questions if you have them on those items. They're all relatively small and admin type items.
Okay, proceed.
Page 192, 2502, recovery support. There's a step 2 reduction. There is a position reduction there and on page 192. And then you'll see below that, there's some other 200 series, smaller reductions there as well.
Proceed.
Stefan, just jump in if you have anything you want to add, and I'm going too fast, all right?
You will.
Page 196, unit 2503, court supervised treatment. There is a step 2 reduction here.
Mr. Chairman, this is the reduction we talked about in court supervised treatment. This would be a reduction to various object codes, including 200 series across the program, and mostly administrative operating revenue. So medical supplies, lab supplies, et cetera, and approximately $793,000 general fund.
Okay, proceed.
Page 201, Unit 2505 is the Wyoming State Hospital, and there are some step 2 reductions here.
Chairman, the first reduction to the Wyoming State Hospital on page 201, you'll see that this was a state hospital position, but like I mentioned in my introductory comments, we have been using this position for years in human resources for the entire agency. So it's an artifact of history that this position was located at the state hospital, but we are eliminating it as part of the step 2 reductions. And also, as I mentioned before, the Title 25 reimbursement rate reduction to designated hospitals is on the bottom of page 201. This will take the per diem reimbursement from 677 a day to 610 per day. Total general fund savings there of approximately $750,000.
Mr. Chairman.
Go ahead.
Mr. Chairman, thank you. On page 204, as an example, just in your 100 series, 368 employees in the Wyoming State Hospital, how many actually exist?
Mr. Chairman, I don't know the number off the top of my head, but we'll get you that ASAP in terms of the numbers that are filled. We are working right now in implementing the staffing plan that this committee and the legislature approved earlier this year. So we still have a number of vacancies, but to my knowledge, all of those that were part of the plan are posted for recruitment.
So, Mr. Chairman, just a follow-up on that. So the plan that was put in place, the 368, is what you put in place in that plan, or in fact, is that a different number?
Mr. Chairman, Representative Summers, good question. This 368, and Eric, correct me if I'm wrong, this would include the new positions that were authorized as part of the last session. So essentially, we transitioned 20 positions internally and had new positions totaling 29 for a total of 49 in the new staffing model. So that would be included in that 368 number.
Thank you.
Okay, proceed.
Mr. Chairman.
Oh, I'm sorry. Go ahead.
Yeah, can we go back to drug courts just for a second? And I'm just curious, what proportion of drug court funding does this represent?
Mr. Chairman, Representative Schwartz, Eric, do you have that number off the top of your head? I'd have to get my envelope out and do it on the back of it.
Yeah, we'd have to look at it. It's the total is 7.3 million in funding, and that's all sources. So there's 3.7 million in general fund, and we cut 800,000 of that in step 2.
Thank you. I mean, partly what I was getting at is how much local funding is contributed to drug courts. And I don't need it right now, but if you could get that to me, it'd be helpful.
Absolutely.
Chairman, Representative Schwartz, happy to do that.
Next unit is on page 205. It's 2506, and it's outpatient mental health, and there's step 3 reduction here.
Mr. Chairman, I'll take the next 4 units if that's okay, because these are all of our community mental health and substance abuse units. So 2506, 2507, 2508, and 2509, all services that are contracted and funded through our community mental health and substance abuse centers. In total, all of these reductions would represent a $15.2 million cut out of an approximate $90 million general fund budget. So it is, this was spared for the most part in step 2. In step 3, it is much more hardly felt. But happy to go through each one of these individually. But all of these units, 2506 through 2509, are all contracted community mental health and substance abuse services.
Any questions on either one of those? 205 through 505 through 509, is that right?
Mr. Chairman, 2506 through 2509.
Okay. Please proceed.
Okay, page 213 is 2510, and this is preschool services. There are 2 exception requests in this unit, and also step 2 reduction.
Mr. Chairman, this is what we discussed before in both the Part C, which is birth to 2-year-olds, and Part B, which is 3 to 5-year-olds. We have a total cut here of approximately 8.8 million. In step 3, as you recall, we do have what Kevin Hibbert had mentioned as a backfilling of approximately half of this cut with savings from the school foundation program.
Mr. Chairman.
All right, Representative Summers.
Mr. Chairman, thank you. So you'd stated earlier that you were doing this or it was done in order to ensure maintenance of effort. Don't you know what you need and for maintenance and effort? And I mean, kind of line that out for me. In other words, I really want to cut this from you. So tell me why not to.
Mr. Chairman, Representative Summers, and I'll have Kevin either back me up or disagree from budget's perspective. 2 things. So Part C is the birth through 2-year-old program. There are federal MOE requirements there, but where we really get into more detailed conversations is on Part B, which is the 3 to 5-year-old program, because that is more heavily regulated by the Department of Education and the IDEA Act federally. So I'll be a little bit blunt, forgive me, Representative Summers, that this essentially puts us at risk when you cut these programs for some loss of federal funds that is very hard to determine in the time that we're in right now. It would essentially be reviewed in the next federal cycle, so next year, and essentially it could be a percentage of our developmental preschool budget. So if we cut $8 million, what percentage of that is did we cut out of the entire program, and thus will the feds ding us for MOE and take that percentage of federal funds? In addition, the Department of Education here in Wyoming has what they call maintenance of financial support for their general special education spending, and there's risk of losing a corresponding dollar for dollar federal fund in their shop if we were to make these cuts. I think that's what Director Hibbert was mentioning earlier as, again, potential risk to see what would actually come down from the feds. And not to be crass, but I think the term, playing the game of chicken is kind of appropriate here in that we have a heavily general funded program that, is difficult to cut because of these MOE and what MFS or maintenance of financial support issues. I think what we have prepared, Representative Summers, both for the governor and for you all, is what do we estimate to the best of our knowledge right now could be lost in MOE compliance issues. And the last thing I'll mention is there are in the federal law, in the federal code, opportunities for waivers of maintenance of effort for a temporary period. For example, if the state has experienced what they call precipitous and unforeseen declines in state revenues, which I think is certainly the case here, you can apply for a waiver for maintenance of effort compliance. Whether they grant those or not is really kind of out of our hands and would have to be worked through over the next approximately 1-year period. But Kevin, please feel free to add in anything that I may have missed.
Mr. Chairman, it comes down to the Department of Education feels like they're at risk on their maintenance of effort. I think that's a question for them to answer. So in that vein, the governor pulled back on this to give us some time to get a better understanding of what the real exposure would be for the Department of Education on their side of the fence for the MOE.
Mr. Chairman.
Go ahead.
So where I struggle with this a little bit is on that Part B side, we put in about, and correct me if I'm wrong, about $236 million a year to leverage $26 million of federal funds, and they're going to hold us hostage. We reimburse these special education funds 100% to the districts, and so what we're at risk of losing is some IDEA money that comes back to the Department of Education and is used for what? Because you can't supplant it. And we're not supplementing because we're reimbursing 100%. And then I think we have, when we took the cuts in 16, I think we took them out of C without any ramifications that impacted us negatively. Mr. Chairman, I just hate to have this IDEA thing holding us hostage when we get so little out of it, and we put, it's so overweighted with general funds. It's just hard for me. I just struggle with that whole concept.
Kevin?
Mr. Chairman, there's experts in LSO, there's experts in this, in education that are better informed about this than the Department of Health experts and myself. But the question is there a true risk to the MOE inside the Department of Education from cutting the funds from the Department of Health?
And Chairman, Mr. Chairman, follow up. But my question is, Kevin, is even if there is a risk, and we lose that funding, how big a deal is it? Because it's only a like amount, and we're not using it it doesn't go to the kids because we reimburse that out of general funds. That's the question. I don't argue with their expertise. I just argue with the rationality of the whole damn thing.
Well, so hopefully we'll have someone respond to that by Wednesday. Otherwise, it might be gone. Senator Grew.
Yeah, I kind of having the same problem. These problems are more geared toward Part B than Part C. We know about Part C, and we know where the funding comes from on that, right? Or are they both at risk on the maintenance of effort?
Mr. Chairman, Senator Guru, there's risk on both sides. I think the sort of double risk to the Department of Education funding is really mostly felt on the Part B side. Part C is just a little bit different, but there is an MOE component there as well.
Okay, further questions? All right, proceed, please.
Next unit is on page, sorry, I lost my place here, 221.
Eric, real quick, sorry, Mr. Chairman, I did want to mention on page 215 as a reminder, the supplemental request for the enrollment growth increase in the child count can be crossed off of your list.
Yeah, that's right. So do we have a list of what the new count is yet?
Mr. Chairman, we do. So the count compared to last year, the count at December 1st of this year came in at 3,389 as compared to 3,645 last year. So that's a total decrease of 256 identified children. In the Part B program, the 3 to 5 year olds, that was a decrease of 190 children identified. And in the Part C program, the birth through 2 year olds, that was a reduction of 66 children identified.
And you have that by county, is that correct?
Mr. Chairman, I do not, but we certainly should, I believe.
Yeah, it'd be nice to see. Representative Walters?
Thank you, Mr. Chairman. Do you think some of those reductions in headcount are because of the COVID issues and parents homeschooling those kids versus sending them to the various child development centers? And so with that, will there be a corresponding increase in a year from now?
Mr. Chairman, Representative Walters, it's a good question. It's really hard to say. Again, there's a number of factors that go into, what impacts the child count, including what you just mentioned with COVID-19 having plagued us for the better part of this year. I will say that you'll see in the narrative for this unit that with the governor's office and with the governor, we had put an option in front of the legislature to allow or authorize the child development centers to use last year's child count. That's a bit of a sticky wicket legally speaking, but I think something that we're more than happy to entertain the discussion, given that some of the centers may have seen a decrease in their ability to outreach, a decrease in families reaching out to them for evaluation services to see if the child would qualify. So there has been a proposal to us to allow them to use last year's child count, which again would be 256 children higher than this year's. But we have to put that in front of you all in the legislature, given our reading of the statute and advice from our attorneys general. I think that would require legislative action.
Mr. Chairman, just
go ahead.
Mr. Chairman. Thank quick, Stephanie or Stefan, what's education non-statutory funds? So when you look down on page 219, and I see you got $4 million in some kind of education dollars that I'm not really understanding what they are.
Mr. Chairman, Representative Summers, Eric, you might be the best to answer that. I believe that is kind of passed through federal funding that for us is booked differently. But Eric, please correct me if I'm wrong.
Yeah, Mr. Chair, Representative Summers, that's right. It's pass-through funding that comes through education. So that's why it's listed as education non-statutory. It's money they transfer to us based on the Part B program.
Thank you.
Chairman.
Go ahead.
Mr. Chairman, thank you. Briefly, for the committee's education or knowledge, there is a task force working on this issue and a bill coming forward to move this out of the Department of Health and into the Department of Education, as Wyoming is the only state that uses two agencies to administer the Part B of this program. Every other state uses their Department of Education.
Yeah, we've had that discussion more than once. Okay, proceed.
Okay, page 221, unit 2511, it's respite care. The step 2 reduction here is actually to eliminate this program.
Questions?
Mr. Chairman, this was mostly a cleanup from previous biennia.
Proceed.
That ends the behavioral health division, and now we'll start on the aging division. So if you will turn to page 224, you have 5001, and that is the aging administration unit. And there is a step 2 reduction, or several. They fall into the office supplies, travel type reductions in that unit.
Proceed, please.
Page 228, 5002. This is the senior care unit within aging. This does have a step 2 and step 3 reduction.
Mr. Chairman, in step 2, this is the elimination effective July 1st of next year of the Wyoming Home Services program. That would be for this biennium, $2.7 million general fund. That would be $5.4 million general fund in the standard budget going into 23-24. On page 229, you'll see the issue that I brought up before, where we have a little bit of a problem where, again, when this was prepared, we anticipated potentially implementing this much earlier than now, or even following the legislative session. So this the step 3 reduction of 2.7 million is problematic in our ability to actually realize those savings. But the program is intended in step 2 to be fully eliminated effective July 1st of next year, in which case you would realize the full $5.4 million budget reduction in the standard budget, but not for 21-22.
Representative.
Chairman, Mr. Johansson, this may be a repetitive question, but on page 226 for Department of Aging, Department of Health, Aging Unit Administration under personnel, no cuts there. So is it nobody's job to administer the WISE program? Because you're going to eliminate the whole program, right?
Mr. Chairman, Representative Stith, I'll get you that number. We do not have a full FTE dedicated to that program, and the majority of the personnel in the aging division are located in our 3 long-term care facilities in Buffalo, Basin, and Thermopolis.
Okay, next unit is on page 232. 5007, the Wyoming Senior Services Board, and there is a step 2 and a step 3 reduction there.
Mr. Chairman, the step 2 reduction for unit 5007 on page 232 is mostly supportive services and a small reduction in contractual services. The step 3 proposed reduction to the Senior Services Board would be a $404,000 reduction in grants and aid payments to the board. Their total biennial appropriation or spending, as I recall, is approximately $11 million. So relatively small in the cuts that we're making, but that's unit 5007 for step 2 and step 3.
Questions? Okay,
Okay, next unit is on page 235, 5010. It's healthcare licensing and surveys, and there is a step 3 reduction.
Mr. Chairman, this is a position elimination for a lead surveyor position in the Office of Healthcare Licensing and Survey. This has been a historically very difficult position to recruit. This is an incredibly stressed staff. They travel all the time. It's hard to fill these positions, but this is one that we have been unsuccessful in being able to fill for quite a while, and we're eliminating it as part of the step 2 reduction. Excuse me, part of the step 3 reductions.
Nick?
Okay, last unit is on page 240, 5050. It's the Veterans Home, and you'll see the step 2 reductions are office supplies, food supplies, medical supplies being cut there in step 2.
Mr. Chairman, that concludes our presentation. 7 minutes over time. Apologize for that, but we stand for any questions, and we have our list and folks listening in of things that we intend to follow up with the committee on. So I appreciate the time today, and we stand for any further questions.
Committee, any further questions for Stefan or
Mr. Chairman?
Mr. Vice Chair?
Yeah, Stefan, how many people do you have in your human resource division? How many positions?
Mr. Chairman, Senator Hicks, I'd have to get back to you on that. We would total those up between with the Cheyenne office and all 5 of our facilities, which have human resource staff, but we can get you that number. Eric, do you have that off the top of your head?
I do not, and I know it's mixed in with our director's office total positions as well, so I'd need to break that out as well, but it can certainly be done.
So, Mr. Chairman, Co-Chairman, follow up. I see if Kevin's still here, I'm assuming that those will all be swept into A&I within the next year. So,
Mr. Chairman, that's the intent of the consolidation for HR, but just keep in mind that across the expanse of the enterprise, if let's say a position was 10% HR and the rest of it was administrative or something, then naturally that wouldn't take place. But yes, there's an accounting of that in the reorganization plan for HR, and we are working diligently with the Department of Health on this reorganization plan. One of the larger challenges that we have, why we can't just rush at this today, is that we do have to be very careful with the Department of Health and the associated federal dollars that are coming in with these positions.
So Kevin, when that reorganization occurs, those positions will be eliminated out of the agency's standard budget that will be presented next year. Is that correct?
Mr. Chairman, that's absolutely correct. It'll be B11'd out, and then we'll follow that up with an appropriation to make sure that it's finalized.
All right, thank you. Mr. Chairman, I'd still like to get the number of HR people and whether they're 50%, what that number is across all the divisions within the agency.
All righty, we'll get that. All right, anything else for the Department of Health? Seeing none. All right, thank you, Mike. Thank you, Stefan. Appreciate your work and effort. It's a big lift for you guys, and this isn't easy for anybody. It's just it's a tough deal. So thanks for your help.
Thank you, Mr. Chairman.
All right, committee. Don, anything for the good of for today, and anything we need to talk about for tomorrow?
Yes, Mr. Chairman. Karen will be sending out a number of follow-ups. There are a good number of agencies who have submitted responses to your inquiries from last week. In particular, the Fire Prevention and Electrical Safety has responded with
our white paper?
Yeah, white paper, exactly. Looking forward to tomorrow, you have the State Engineer's Office and the Department of Workforce Services are your last 2 state agencies for which, or who will appear before you. Beginning at 10:15 and are the governor's letters. And again, we've talked about 3 or 4 letters potentially from the executive branch. At 11:30 starts the public comment period. As of right now, we have 10 individuals who have signed up, although one of the individuals has asked to appear on 2 separate topics. They have 2 different clients, I think. Of those 10 individuals, it also includes 1 senator and 1 representative-elect. We can extend that time period. I think you have enough flexibility if you wanted to spill that over after lunch as well, or it's quite possible that the governor's letters will not take the full hour and 15 minutes, which have been allotted on the agenda. In terms of callbacks, we only have 1 so far, which is the Parimutuel Commission. They're scheduled for tomorrow afternoon. We do have the ability to insert others on the agenda if you so desire. Absent that, we will start, and with your direction, we will start the markup of the 21-22 supplemental budget tomorrow afternoon.
Mr. Chairman?
Go ahead.
Don, just a question. I didn't see it today, but did we get a response from the Livestock Board from our letter?
Mr. Chairman, I believe the Livestock Board has responded, yes. Again, I think it's, all of these will come out shortly from Karen, I believe.
I think I forwarded that on to you last week, Albert.
All right, any other questions? If not, we will stand in recess and reconvene at 8 tomorrow morning. We'll see you all bright and shiny early.